Hello, everyone. It's my voice clear to all of you? A very good evening and welcome from Sidra's side. Am I audible to all of you out there? Can you all hear me?
Yes,
Is my
Dr.
voice?
Sidra.
Okay, thank you very much. Thank you. Thank you, Bindu. All of you, thank you for joining in. And the ones who have not joined in, please send a reminder in the main group so that we can begin. A very warm welcome to the first session of sexual and reproductive module today. We will try to make it very easy. We will try that all the important aspects of this module we cover today, and you all are in a good flow for this module for future and for exam presentations. So to begin with, I know it's a tough module to begin with because there are certain sort of complications in terms of dealing with young people in this module, but still we are going to try that this module becomes easier. Now, whenever I used to prepare for my exams, remember, I used to pick up the toughest things earlier, the hardest things earlier. Reason being, whenever you do the easy things, yeah, it is important because you get confidence that yes, it's being covered. But at the same time, the hard thing, the tough thing keeps on ringing in your ears that okay, that's left. So the sooner we get over with the tough things, better it would be. So nothing to worry, all would be going great today. Good luck to all my presenters today. So are we all ready to begin with sexual and reproductive health? Yes, Talia, Pallavi, Ramya? Yep. Okay. So a quick reminder for all my students who are going to present today, read very carefully all the words. You should be a fast reader and every word is important. Please give 1 minute for the reading and at least 40 seconds to make your outline as I told you in the introduction. Right? Got it, everyone? Did you all get that? Thank you very much. Okay. So we had a slight change here. Instead of Salma, thank you very much to Harshabad as she volunteered. I would like to make a small suggestion here because everybody is committed. Everybody has some household chores as well. And along with that, the commitments at the hospital as well. So you know prior that who is going to present next week. If you have any commitment or any change in the sequence of the presentation, I would just make a suggestion that do it earlier so that somebody else can take your place in that time period. Okay, point noted, everyone. All right. So the module of sexual and reproductive health. All right, Girija, we are waiting for you. Sexual and reproductive health basic template we discussed in the last session. If it's going to be sexually transmitted disease, if it's a vaginal discharge, do ask about that. If it's a contraception, ask about the unprotected sexual intercourse, menstrual cycle, do ask about the partner history. Always remember, do a sign posting. It's just a quick recap. Do a sign posting before the sexual history and ensure confidentiality so the young role player is open and is confident talking to you. Don't forget the phrasers, or if it's a termination of pregnancy, Gillick competence, because it's important. Don't forget the safe sex in young, specifically young individuals. Gynae history, obstetric, medical, family, surgical, drugs, and personal, you all would go in the same manner. Then it would be social and mental. Then it would be examination if required in that case, and management would be according to the station. You will ask if some concerns are there you need to address before closure, and then you're going to close your station. Friends, I've given you the syllabus. Now that syllabus is basically containing all the topics from different sources, different books, important exam topics which had been touched earlier. It contains different type of courses, questions. So all the topics are there in that syllabus. Now, out of that syllabus, that needs to be covered for exam, right? Out of that syllabus, I pick up like 7 to 8 questions which are important from the examination point of view, and I post that earlier. Now, yesterday, I got a clue from a mini group that they were preparing the entire syllabus. That's good if you can do that. I appreciate that. But doing that and not preparing those 7 stations which are going to be done in the session, which you're going to be present, anyone is going to get out of those stations, then I think you'll feel a little lack of confidence. So my suggestion would be that complete those 7 topics prior. Once these 2 months, 2.5 months would be over with these sessions, you can go back to revision of the module and you can complete your leftovers from the books. And I'll give you the schedule for books as well, that now all the mini groups will be doing this book once we are over with these important stations. Am I clear? Am I clear? So second revision, go to the same module. My point is that rather than doing 15, 20 stations and not having a command on these 7, 8 stations, which are important exam stations, so that is going to make you a little difficult in your preparation. I hope you get my point. Because doing 20 stations and not having a command on those 7, 8 would be difficult. So do those 7, 8 stations perfectly. When I mean perfectly, because if there is some sort of a repeat station, that should be perfect, right? When you're coming back to the module for revision, then you have highlighted on that syllabus of mine that these topics are left. Now we need to cover that in the second go and revise your first go stations. Am I clear? Yeah? Yes, Devya, this is what I mean to say. Why? Because then it's going to be comfortable for you that, okay, at least this part is done, rather than doing every topic half-heartedly. Of course, 7 days are a little less for doing like 20 topics. Okay, Girija, clear? So please go through that. Do I have Dr. Atiya, Sarwat, Dr. Sabia? Nobody from batch A is in the chat box. 2 Sarwats, Dr. Atiya?
Yes.
You're here? Okay. I was waiting for you guys in the chat box. All right. So
Yeah, actually.
Okay. Thank you very much. Thank you. So these are the topics from the syllabus. And one more thing, when I write the sequence of the topics in the study group, that these are the topics which we are going to do on the next session, 1, 2, 3, 4, 5, 6, 7, 8, that does not mean that the sequence I'm going to follow according to the sequence of the students as well, because I always change the sequence according to the requirement of the students, in terms of I analyze students that what do I want to have from their side and what is going to be the station where I want to judge them according to their individual requirements. Okay. So, okay. Thank you very much, Dr. Sabia. Now, so don't think that, okay, station number 1, if it's that assault there, so the Jyoti is going to present station number 1, so it would be sexual assault. Okay. So it's going to be random for all of you. According to that, I'm going to, according to your assessment for myself, like today, if somebody does an easy station, good. Next time I always step up, that I have to give a little difficult station so that I can analyze that your graph is escalating and it's rising rather than going down. Okay, right? So are you all ready to begin with the 7 stations for today? Are we all ready? Get set, go. Yep, that's perfect. So do we have Jyoti here? Jyoti had to go for a night call, therefore I shifted her to the first station instead of Dr. Atiya. Dr. Atiya would be doing the second station. That's perfect, Girija. That's like my girl. Okay, so Jyoti, can we hear from your side? Please check your mic. Hello, Jyoti. Girija, where is Jyoti? Jyoti, you requested me for the first station, my dear.
Yeah, she's asking for the link actually. I think she'll join in soon.
I would request that please be prepared for your sequence. Jyoti, a link is in the Girija. Link
I'm sending it on the mini group as well.
Okay, that's fine. I think she got that. Okay, she got that. Right, she's joining in. Okay, so let's begin with Jyoti's station, and I'll fix my 2 minutes because she had to go for the duty. Therefore, I shifted her to the first station. After Jyoti, it's going to be Dr. Atiya. I hope, Dr. Atiya, you have joined. Dr. Atiya is here as well. Dr. Sabia, Sarwat, Dr. Atiya is here.
Yes, she is
there.
She
is there.
Okay, thank you.
I can see.
Much. Thank you very much. Thank you. Right. All right. So Jyoti joined in? No? Okay, let's begin with Dr. Atiya. Dr. Atiya, let's do the station because everybody is waiting. So we'll take Jyoti as second, no problem. It's fine. Both the stations are almost the same. Yeah. So Dr. Atiya, can we start? Can we check your mic? Hello. Am I audible to all of you?
Yes.
Yes, yes.
Audible.
Dr. Atya, knock knock. You should all be ready, guys, for your presentation. I posted the sequence earlier. Okay, it's fine. Now, if Dr. Atya and Jyoti want to do later, let's take Harshiba to begin with. I have given the stations according to your requirements, as if I feel that I would like to test you guys in that. And this was the date and the time which you all decided, right? So in none of the batches this has happened.
Hello,
So
sorry, Dr. Sudra. My connection was getting a little bit disturbed. That's why I was not able. I was trying my best to connect and reconnect. Now it's connected.
Dr. Atya, right?
Yeah, that's okay.
Yeah.
Okay, no problem, Dr. Atya. I understand. Jyoti. Okay, we are starting with Dr. Atya, and then we'll take Jyoti, right? Okay, no problem.
No problem for me if Jyoti wants to take, like, I have no issues.
No, I understand, but she has not joined yet. So she'll be joining, no problem. She has actually called today, so she'll take the second station. Okay, so you all can hear Dr. Atya?
Yes, we can hear.
Okay. Right, so let's have 2 minutes. Dr. Atya, your time starts now. Good luck.
Where is the station? Achha, okay.
Can we begin?
Yes, doctor.
Yes, please.
Hello, I'm Dr. Rahman, one of the doctors in the contraception clinic today. May I confirm your name and age, please?
Yes, hi, doctor. Doctor, I'm Isla John. I'm 15 years.
Okay, nice to meet you. May I call you Isla? Is it okay?
That's okay. Yeah, that's okay.
Okay, Isla. I can see that you are here to discuss some emergency contraception, and you had some unprotected sexual intercourse like nearby, and we are here to discuss your options. Is there any special expectations for this consultation?
That's it. I just want an emergency contraception, doctor.
Okay, right, Isla. Isla, I need to ask you questions regarding your sexual health and regarding your history, so that to know more about you, and then we can discuss the options open for you. And would it be okay?
Yeah, that's okay.
Okay. I assure you, Isla, what will be discussed here will remain perfectly confidential, and whatever discussed here will be with you, and nobody will be revealed until and unless you wish to.
Yeah,
Is
thank
that
you,
okay?
doctor. Thank you very much. Thank you. Yeah.
Okay, Isla. So tell me more about like what happened when it happened, the unprotected sexual intercourse.
Yeah, it was one day back, doctor. Actually, generally we use condoms, but it didn't work one day back, yesterday, basically. So, I actually had an unprotected sexual intercourse, and I'm really fearful. I do not want an unwanted pregnancy.
Right, your concerns are very valid. And may I know when was your last period?
Yeah, that was on 29th of June, doctor.
Today is 9th of 10th of July. Okay, right. So you are 11th day into your periods. Tell me more about your periods. Are they regular? Are they coming perfectly at the same time? Any pain during the periods?
No, I don't have any problem with the periods. They're spot on after 28 days, and they come for 7 days. Yeah.
Mm-hmm. All right. And are you using any sort of contraceptions nowadays?
We just use condoms, doctor.
Other than that, like
No,
any pills, anything?
no.
Right. Thank you. And tell me more. All is going well. This was your regular partner or some new? Or are you seeing anyone nowadays?
No, he is my regular partner. He's my boyfriend. Yeah.
Mm-hmm. And in the last, like, did you ever had any other than the boyfriend, any encounters for sexual intercourse other than the boyfriend last few days?
No, no. I'm just sexually related to him only at the moment.
Okay, so this was the only unprotected sexual intercourse in the last 10, 11 days before
Yeah,
from the
yeah,
last week.
yeah.
Okay, right. Thank you. Okay, and regarding like, I may need to ask you intruding questions that may sound a little bit about your sexual history. Like, have you ever been treated for sexually transmitted diseases?
No, never.
Okay. And did you suffer from any of the discharges, any abnormal foul smelling discharges from down below?
Never, doctor.
Okay. Any bleeding in between the periods or after the sex?
No.
Okay. Thank you. And regarding like, have you ever been pregnant before?
Never, doctor. No.
Okay. And what are your plans for future fertility?
Fertility? No, 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 doctor. Not at all. I don't plan a baby. Of course, not
Uh,
at least before 2025 years.
right. Thanks. And are you overall medically fit and well?
I'm otherwise fine. No issue at all.
No high pressures, no sugars, nothing.
Nothing. Yeah.
Okay. Any surgeries in the tummy or down below?
Never.
Okay. Do you have any allergies specifically, like to any metal, copper, nickel?
No, no, nothing, doctor.
Okay. And what are your like history of having any social like do you smoke?
Yeah, I do. Yeah.
Okay. Is it a regular smoke or like how many cigarettes
Maybe
a
maybe
day?
3 to 4 cigarettes a day, doctor.
Okay. Right. And regarding your alcohol?
Occasionally, just with friends. I mean, I'm not very regular in that.
And recreational drugs?
No, no, no.
Okay. All right. Whom do you live with?
I live with my parents.
Okay. And are they aware of your sexual activity?
No, I never discussed with them. I never found this thing to be very important to discuss with them.
Okay, right. No issues. Just for my information, just to cope up with the things. That's why I need to know it. And everything is okay at the home and no
Yeah,
problem.
yeah.
Right. Okay. Thank you very much for all this information, Isla. Now coming to that, anything you would like to add for me?
Yes, doctor. I would just like to tell you that I have a little concern. Yes, I want emergency contraception, but at the same time, would like to tell you that I've always been fighting against my height to weight ratio. That's around 27. I'm 73 kilograms. So I hope it doesn't make any difference to the management.
The 73 kilos and the 27 BMI, it doesn't matter that much, but we will just, as we discuss the option, we will discuss this concern also.
Thank you.
Okay, so as I can see that your history is quite doesn't have any risk factors. So whenever, see this, I make a diagram for you. This is the womb. These are the tubes, and these are the ovary. Every month, those who have a regular 28-day cycle releases one egg every month, or at the day 14 of the cycle. So you are at the moment in the day 11 of your cycle. This means still the egg is not released from your ovaries. Are you getting me?
Okay. All right.
Okay. Right. So there are two types of emergency contraceptions which can be offered to you. There are some medicines and there is one type of loop. The medicines are usually working that it does not allow the release of the eggs from the ovaries. So it prevents from pregnancy to happen. Whereas the loop works a double way, and it's more better emergency contraception because it also prevents the implantation of the pregnancy if so happens inside the womb, and also toxic to the sperm. Are you getting me?
Yeah, I am. Okay.
Okay. So ask me any questions anytime you don't understand me.
Okay.
Right. So at the moment, as you are in the day 11 of your, any preferences for you for emergency contraception?
You told me about the thing which is toxic to the sperm, right? That is placed inside the womb. Am I right?
Yes, that's
Yeah, I'm a little
inside the womb.
uncomfortable with that. I think I would like to go with the pills.
All right. So the pills are called Livonal and Ella-1. The Livonal is the levonorgestrel. These are the names of the medicine. And usually, as you told me, it's only one day that it is less, only 24 hours has passed since you have done an unprotected sex. So the Livonal is usually the preferred choice, as it works within 72 hours to prevent the release of the egg. But nothing is 100%. It usually works up to 85%. It does not allow the pregnancy to have the egg to be released. It delays the release of the egg. Do you have any questions so far?
No, that's fine. That's fine. If it's suitable, I can take that, right?
Right. And this is usually taken at the same time. Like we can just write a prescription for you. You can just take it now. But I need to inform you few of the things. Like if in case after taking within 2 to 3 hours you vomit or you have some dizziness or something that you throw out, so you need to repeat the dose again.
How much I need to take, doctor? And how much I need to repeat? That's the same like complete tablet?
Yeah, 1.5 grams of the tablet is given. And due to your weight, I will just consult with my pharmacist and the BNF that you may need to take a higher dose of Livonal, that may be a little bit higher dose. And we will just write a prescription for you, so you can just take it right away from the pharmacy.
That's fine. And may I know that, can I take a little time? I mean, I can discuss with a partner. Maybe he wants me to take something like coil. If I can discuss with him, I'll get back to you.
You're sure you are, but I need to inform you that this Livonal can work up to 72 hours from the last unprotected sexual intercourse. Whereas as you have it's with the regular partner and no discharges, still we usually, and you're using a condom, that's a very good thing. That's a safe sex practice. And so it will going to be good. We will just take some swabs from the down villages to make sure that you are not suffering from any sexually transmitted infections. And regarding your partner, you can just take this written information, you can discuss with your partner, you can come back, but come within 72 hours of the last protected. Otherwise, if it's more than 72 hours, so the coil can only work till 5 days from the last unprotected sexual intercourse. And the other one,
I'll get back to you after discussing with the partner, doctor.
Okay, right. Thanks. And I just want to discuss a few more things. If you could wait a few minutes, is it okay?
Yeah, okay, yeah.
Yeah, as you told me that you are smoking 3 to 4 days cigarettes per day. So have you ever thought of quitting, or have you ever thought of the hazards of smoking on your health?
Never thought of that, doctor.
Okay, right. This is a written information. Just read about this smoking hazards and everything on the NHS website. And smoking is generally hazardous for your health and for your future life and fertility also. And therefore, it's whenever you think of quitting it or doing some counseling over it, there is NHS Stop Smoking Services. I can connect you, or your GP can connect you with it.
Thank you, doctor. I'll think about that. Thank you very much. Thank you.
Okay, so this is the contact details of ours. You can just contact me whenever you just decide within this 72 hours, and I will fix another appointment as soon as possible and read this written information. Thank you for your time.
Thank you very much. How was it, Dr. Athiya?
Allah Akbar. It was like, mujhe lag raha tha, I even don't know what to say in the counseling.
No problem, no problem. Anything you think that you could have done, you did better? In fact, tell me your good points, where you think that things are went a little good. Yes, friends, how was the start of the roller coaster? Yes, Rahma, Harshiba, how did Dr. Athiya do? Dr. Sabiha, Sarwat, how did the leader do?
Yeah, I will. She did well, but there were. She was confident enough also, but maybe this is what she is saying. She forgot some points like partner age, consensual
Very
sex,
good. Yes.
HPV vaccine,
Yes.
and double dose of LNG, and
Very
encourage her to
good.
use
Very good.
IUCD.
Very good. Very good.
Encourage to use
Well
her
done.
IUCD as a long term because she is at risk of again and again these
Very
unplanned
good.
pregnancies.
Well done.
Few
Well
things.
done. And I specifically told about the BMI
And
just for this
encouragement
reason.
about information of parents. Like 4-5 things.
That was fine if she didn't do Savat, because that was not a termination, right?
But maybe this is because we are listener. When we are in hot seat, then we will also forget the same things.
Exactly. This always
all other will be
happens.
remembering all things.
This always happens that whenever you're on the hot seat, you tend to forget the things. And whenever you are a listener, everything comes in your mind. And that is very natural. So a very good attempt, Dr. Athiya, to start with. The best thing was your tone with a 15-year-old girl.
Right.
That was commendable. This
The
tone was
safeguarding,
commendable.
I have written in this 2 minutes my 5-6 points in which I write safeguarding, and I didn't bother even to look on the points which I write.
What did you write? Dr. Athiya, what did you write?
I write the name especially, and I write all domains. So I write P, N, C, C, APK.
Okay.
And then I write HOPC, I write the stars, I write LMP, I write safeguarding, I write P for the past medical history, S for social surgical, all this allergy specifically. I write all the things, smoking and alcohol, A, S, everything I wrote in the short letters.
Okay.
But after that, I forgot to look even what I write.
Okay, no problem, no problem. We'll do a training in a manner that at least our time, consuming time and reading goes side by side, that at least you tick your points that, okay, that is done and I'm moving forward. Okay, something which you think should have been done to pass the patient's safety and apply clinical knowledge, despite doing a lot, speaking beautifully.
The safeguarding, the partner's age, I didn't ask.
That is for the patient safety, yes.
Yes, and for the double dose, that also comes in the patient safety.
Yes, see, giving a wrong dose after the end of the 10 minutes, basically no matter how good you do. That's why, when you missed in the history, I specifically told you that BMI is more. Yeah? So that was the point that I had to tell you that my BMI is more, give me double dose. Did you people understand this when I came to this thing? That third thing is that, thank you very much, Girija. Third thing is, remember, in an emergency contraception station, never send the patient back home. It is against the patient's safety. I respect that she can take in 72 hours. But Athiya, what happens is that every passing minute makes you go towards the failure of the contraception. So sooner the better. This is patient safety, right? So it is that, yes, she has come here and you say that, yes.
I offered her prescription, but after that she negate now because she don't want it now. She wants to think.
Now, her concern was that I want to discuss with the partner, right? So what would I say? I would say, yeah, sure, Isla, you can take your time. I'm right here. You can discuss with your partner. This is the information leaflet and let me know. I will just give you the prescription right now. Please take your few minutes. I'm waiting for your response.
Okay, take a few minutes.
Remember why? Because 15 years old, she doesn't understand how important it is. And moreover, whenever the passing time is more, the efficacy and the success of the emergency contraception is going to decrease. It should be taken in 72 hours, or for that matter, for 5 days for ulipristal acetate, but it does not mean that you wait for the last 5 days to end up. That means that sooner it is taken, better it is. Do you get my point? This is your patient safety. You tell her that, please, yes, you can ring your partner, you can discuss with him, and please let me know about the decision. I'm just right here waiting for your response. This is the ideal way to do that. Do not let a 15-year-old girl go back home. She'll be coming back with the unwanted pregnancy. Did you all understand this point? It is patient safety in emergency contraception that you have to give emergency contraception sooner rather than asking her to come back. So I tried to trap you there. I wanted to listen to these words that sooner we take it, better it would be. So I would suggest that you make your decision today. Right now, you can discuss with your partner for sure. I'm right here waiting for your response. So this is the ideal thing, that, you know, whatsoever she wants, do it today rather than waiting, making her having a risk a little more if we wait for more, okay? Let's begin the feedback. Starting with the domains. Introduction, I was happy with your introduction. You said, nice to meet you. That was good for a 15-year-old girl. I gave you a star on that. Agenda making, when you made that, there was a little fumbling in the agenda making that you had an unprotected sexual intercourse, therefore you want emergency contraception. I would like to rephrase it, Dr. Athiya, just like, Isla, I have gathered from your notes that you're here because you seek emergency contraception. Is that right? Yes, surely in the next few minutes, I will be discussing about your options available. Before that, can I ask you questions to know a little more about you? And now I will ensure confidentiality. So there was a little fumbling there because you were changing questions. So that my expectation is that goes a little in a flow, though I have passed you in communication with the patient. I have passed you 2 by 2 in communication with the patient, but still a little fumbling I would avoid in the first 2 minutes, and we'll work on that, how we have to be smooth in our first 1.5 minutes, okay? Now, when you came to the information gathering, you made a very big signposting of information gathering, Dr. Athiya. When you'll go to the recording, please have a note of that I would like to ask few questions that would be regarding your sexual health and general history. So that is not required before the signposting. My point is that we should be crisp. So give a simple signposting before the information gathering. That is, I would like to ask few questions to know more about you, and then I would be offering management plan options to you. Is that all right? So, you know, to more about you is fine. That would be regarding your sexual history. That would be regarding your medical history. We don't need to do that. Do you agree? Because what happens is that time starts getting consumed. So just make one line to know more about you. That's it. That is sufficient to tell her that I want to take history. When you came to the information gathering, you asked about the unprotected sexual intercourse first. I told you that it's 1 day back. Here I have a point to tell all of you, please. Whenever in an emergency contraception, there's a station of emergency contraception, 2 things make you decide about the emergency contraception. Number 1, it is unprotected sexual intercourse. And number 2, how much duration has passed. And number 2 is the current day of the menstrual cycle. Now, my way of doing that was different. I never used to ask, may I know when was the unprotected sexual intercourse? Yeah, or the details of that. And second day, when was your last periods? As I purposely told Dr. Athiya 29th of June, so that she can count on her fingers. It was easier today because she memorized the date. And believe me, in exam, you don't do that. You forget that what the date is today. So what is the wise way of asking? Do you need to know about the last day of cycle, or do you need to know about the current day of menstrual cycle? My way would be that, may I know your current day of your menstrual cycle? That would be my question, because that would give me the information which I require. So why not to formulate the question in a manner that we get the right information? Because if you start counting that in your fingers, your 12, 13, 14 days might get up and down under confusion and nervousness, and your management get changed because of if the 14 days is crossed. Do you people understand my point, that how we have to ask that? Now, when I said 1 day back, unprotected sexual intercourse, Dr. Athiya, my second question would have been, I said 1 day back. My question would have been that, may I know precisely how many hours back, Isla? Because one day can be more than 24 hours as well. You don't know when it was in the morning and when are you seeing this patient today. You should be very clear. In one day, it doesn't matter much, Dr. Athiya, but yes, in 2 or 3 days, it does matter. Because if she says 3 days, you don't know it's within 72 hours or 72 hours have crossed, because the 24-hour clock, that in days that goes different and in hours it goes different. So again, my question would be, may I know precisely how many hours have passed? And my way of doing that was that after I asked about the unprotected sexual intercourse and the LMP, then I will echo the patient. You beautifully echoed the 11th day. I was very happy on that. Then I would say, okay, Isla, what I gather is that you're in 11th day of your menstrual cycle and around 23 hours have passed since the unprotected sexual intercourse. Am I right? Why would I echo that? To tell the examiner that these are the 2 points which I wanted to know to give her the options. Am I clear so far? These are the first 2 questions where I would repeat. I would ask, may I precisely know the number of hours passed from the last sexual intercourse? May I know your current day of menstrual cycle? Make your life easy in exam. Don't put yourself in difficulty. Am I clear about these 2 points? These would be my first 2 points in the history taking. And I was happy.
Yeah, I would like to know that after that, may I know the current day of your cycle? So after that, I will ask about cycle details in the same time?
Yes, yes. Is it regular?
Okay.
So then it would be that would be a valid thing. So this is a wise approach rather than, putting yourself under nervousness. So these are the first 2 questions of the history, friends, okay? Then menstrual cycle history, you can take from this current day of the menstrual cycle. Is it regular? Intermenstrual bleed and postcoital bleed, I will ask here, Dr. Athiya, rather than asking, you asked it in the STDs. That's fine, but I would like to ask here. So any problem like bleeding in between the periods, Isla, or after the sex? So then I would come to this. Then you asked about the contraception history, about the condom use, that was all right. You asked about the partner history. Again, there was a little fumbling there. I have written down, be very open and very confident in asking this question. Your tone was very good. So Isla, may I ask you questions regarding your partner? Is he your regular partner? Was it a consensual sex? May I know his age? Thank you very much for informing me, Isla. That's it. Your job is done. Right? So just in one go, in a smooth manner. Though I've passed you.
No, I don't get you.
Yes.
This I can understand about this, that may I ask, was it a consensual sex? But what about like a regular partner? So like 15-year-old girl says it's a boyfriend, then it's a confusion for my own self. Your boyfriend is different.
No.
And
You say that is he your regular partner or a casual one-off?
Regular partner, casual one-off. Okay.
Yes, this is the statement we say. Regular partner means the one she is regularly having the sexual intercourse. Casual one-off, that it was something random which happened. Okay, so this actually tells us that how is the relationship. So I told you that yes, he is my regular boyfriend. So this one.
That's what I am confused about. Boyfriend. Like in others mentoring, I have learned that boyfriend doesn't mean she's sexually active with that person.
No, that's why I'm saying that I am telling you that yes, I'm sexually active with my boyfriend. So that means that he's my partner, right?
I get it.
Okay, I'm telling you that yes, he is my regular partner. So I'm clarifying this point to you as a role player. Okay.
Right.
Now, after coming to the partner history, you did a little signposting about the intrusive questions and you asked about sexually transmitted disease. Again, you said that my few of the questions would be intrusive, but I would like to know to formulate a management plan. And then you said that, did you ever have any sexually shared infection? Just rephrase that, Dr. Athiya, by saying that few of my questions might sound a little intrusive and personal, Isla, but I would like to know to formulate the management plan for you. Can I proceed? So this can I proceed again is important because she says, yes, doctor. So she's not taken aback by your question. So can I proceed? Just add. Your signposting was fine, but without asking you came to the question. So I would just suggest that add, can I proceed there? So she would say, yes,
sorry
doctor.
to interrupt you again. In that one partner history, in this station, I have to ask that how many partners did you had before?
No. Okay.
Sorry to interrupt.
No, it's okay. Now you came to the obstetric history, that was all right. Then you came to the medical history. I would like to do a little detail of the medical history. Why? Because the hormones I'm giving, I'll just tell you in the template I've given. Then surgical history, allergy regarding the metal, that was all right. You asked about the support, how's everything going? That was all right. So information gathering, I would give you 1.75 out of 2, 2 by 2 in the communication with the patient. 1.75, just cutting your 0.25 for not asking the partner history in that age. That comes in safety as well. That comes in information gathering as well. And precisely asking about the number of hours so that you don't forget in future, okay? Now coming to the plan of the management, visual aid is always important. Visual aid is always appreciated in the station, but it was not required here because we are not dealing with the pregnancy, right? So ovum is released and the tubes are there and it is attached here. Because we are dealing with the cycle thing, you can simply say, even if you do that, that's not something harmful, but even if it's done, that's something which will not even give you additional points or not even deduct points. So it is something which a good idea, always we appreciate that. Explanation. You enumerated the pills and you copper coil. The best thing was that you noticed and you asked my desire that what am I comfortable with. That was very good. But applied clinical knowledge went wrong in 2 places. Number 1, even if you give 1.5 milligram, go to the recording, you said 1.5 gram, right? That's number 1. Another thing is that the dose you had to double up. I should not add in the BMI in history with smoking, alcohol. Remember, ask for the BMI in the emergency contraception. Make it one sequence in the personal history. Smoking, alcohol, may I know about your height to weight ratio? So that you don't forget. The best thing you did was that at least you gave me an opportunity to add into something. If you would not have given that, even that would have been missed. Yeah. So I had something to add that was very good. When I added that, I wanted a double dose. So here applied clinical knowledge went wrong, for which I'm afraid I cannot score you. And patient safety. 1 was partner's age. 2nd was giving a wrong prescription. And 3rd, important patient safety, anybody could tell which was not done in the station, for which I cannot pass this to me.
Checking competency.
Very good. Well done. Fraser competency. If you're not going to judge her for the Fraser competency, and if you're not going to assess her, this domain would be failing. So what I would say is, Isla, may I know did you understand the options available? Can you repeat that for me? Can you pick up the best option for you? These 3 questions are mandatory because these are assessing the mental capacity. See, mental capacity is not assessed by school grades. Mental capacity is not assessed by she's a topper at the school. These 3 questions are important to assess the mental capacity. No matter she's younger than 16 years, no matter she's an old lady where we need to judge. That means that she can retain the information, she can repeat the information, and number 3, she can make her decision. Right? Now, in the end, you can discuss about that. Not today. You told
Dr.
about the
Sidra, can you please repeat the 3 questions, how
Yes.
to ask?
Yes. Isla, did you understand the options available? Can you repeat that for me? Can you pick out the best option for you? Or can you make your decision? So these 3. And the 4th point for which I am not able to pass the patient safety is sending her back home without. So these 4 points are mandatory in emergency contraception, which we're all missing. Let's go to the feedback and the template.
Dr. Sidra.
Yes, my dear. Yes,
Sidra, I don't know if she has counseled her about the safe sex, to use condoms.
She did. Yes, she did say in the end that please use condoms. They are important for your health. That's important. Okay. Right. Yes.
If in this case, if while we are competence and we find her to be Fraser incompetent, how do we close this?
Generally, they won't give you Fraser incompetent patient.
Okay.
Yeah. Why? Because there's a lot to discuss in emergency contraception. They do give mental capacity lacking patient, but in elderly, generally they give, and then they have some daughter or something to talk to you with the power of attorney or advance directive. So I'll do that. I'll do that in oncology module with you guys. That's an Alzheimer patient. Yeah. Okay. She has forgetfulness. Here, the patient is very wise in emergency contraception because of course you have to give that. Like the way I was talking, I was competent. Like, that yes, I will talk to partner. Okay, coil this. And I was wise patient, but still From Dr. Atiya's side, I want these questions to tell the examiner that yes, I know that I'm checking the phrase's competency. Okay? Now, communication with the patient, Dr. Atiya,
All right.
I'm happy with your communication with the patient. I'll give you 2 by 2 in this. The tone was perfect, friends. Mimic the tone, Dr. Atiya, the way she talked to 15 years old girl. She was having an attentive listening. The best part was she was echoing the information somewhere in between, and she was checking my understanding. And she had a very sensitive approach talking to the 15-year-old. So very well done for this domain. For information gathering, I will cut just 0.25, though it's a passing domain. You were very good in your information gathering, but 0.25 for certain things which I've mentioned. The first question is episode of the unprotected sex. Please ask precisely the number of hours. Menstrual history, please ask about the current day of the menstrual cycle and then the duration of the menstrual cycle. Sexual partner details, do a signposting, ask about the age, the consensual sex. Is he a regular partner, right? Contraception, regular contraception. This is the 4th part of my HOPI in my emergency contraception template. My 5th part about STI. So these 5 are HOPIs which you need to make in your template for emergency contraception, right? Asking about any vaginal discharge, any rash, any lower tummy pain, sexually shared infection with the signposting as Dr. Atiya did. Then you come to the gynae history, obstetric history, medical history. I would like to name Dr. Atiya. May I know any problem regarding the personal history regarding the clots in the legs, half-headed headache, migraine, asthma, or any liver problems? Why am I doing that, Dr. Atiya? Because we know in asthma with steroids, in liver diseases, we can't give ulipristal acetate. Remember? Yes. So for these issues, I will speak in one line to tell the examiner that I know medical history. She's a 15 years old girl. She might not feel okay telling for emergency contraception, asthma is important, right? But I would be asking that to tell examiner that, yes, I know that. It would just take 5 seconds. In personal history, I would cover up BMI first and then smoking. This was my way. I used to associate BMI in a personal history. You can do that early as well, but do not forget that, because in emergency contraception, when they give the station, what they do is they put some sort of contraindication or some sort of enzyme inducers. Why? To make a change in the management plan. So they put something so that you can change and you can tell her that what suits her best. In examination, you said correctly that I'm going to check for the discharge. If it's there, I'm going to send swabs. And investigation prior to deciding for the coil, swabs have to be sent. You said that was good. When I decided for the coil, that I'll be thinking about that. Patient safety, suitable emergency contraception was not given. Phrases was not done. Contraindications like BMI, double the dose was not given. So this was one domain which I would not be able to pass, and similarly applied clinical knowledge as well. These 2 went wrong and the first 2 domains were better, right? Now in applied clinical knowledge, friends, I would like you to tell 3 things about each of the option. Number 1, mechanism of action, as beautifully Dr. Atiya said, that it prevents the egg release from the ovary. And copper coil, the copper is toxic to the sperm. So at first place, the meetup of the sperm and the eggs does not happen. If at all it does occur, the attaching of the pregnancy to the womb, it prevents that to happen as well. So this is going to be your mechanism of action. Now, Isla, I would like to tell you that 85 out of 100 women, they have a successful prevention of the pregnancy by taking Livonel in 72 hours time of the unprotected sexual intercourse. However, the LR1 has 98 out of 100 success within 120 hours, and copper coil is the most successful in emergency contraception in preventing the pregnancy, and 99 out of 100 women, they have the success in that. May I know, do you have any special concern regarding any of the contraception? So now she says, I'm happy with the pill. I was glad that Dr. Atiya mentioned about the vomiting thing as well. But remember, now before giving that, do check the phrasers by repeating the options. Can you repeat the options? Can you make a choice? So this was a note done, and I'm sure now whenever this station would be an exam and I would be ringing in Dr. Atiya's ears that please do the phraser. Don't forget that. Please ask about the partner's age. So doing mistakes today, doing mistakes today is always having its benefit rather than doing on the exams day. So don't worry about the things which we are doing today because we are learning. And on exams day, we will be perfect. Now, I brought this contraindications from emergency contraception for the reason that this is how they formulate the exam question. They put something in the question which makes you alter your management plan. For example, I made a BMI higher. They can give an enzyme inducer. So Dr. Athiya, if it's an enzyme inducer, what would you do?
I will double the dose of
Very good.
levonorgestrel.
And about ulipristal acetate, what would you do?
Enzyme inducers to be not given 28, some interaction, I forgot 28 days.
We will not give ulipristal acetate, no matter single dose or double dose, yeah? In enzyme inducer, friends, you will tell about the 3 options again. This is another station, that's why I'm discussing that. You will discuss the 3 options and then say, for the liver now, we are going to double the dose for you because you're taking this medicine for the epilepsy, for example. But however, the ELA1 is not suitable with this drug. It is absolutely contraindicated. So remember that for ulipristal acetate, it is absolutely contraindicated. 3 milligram levonorgestrel, it's milligram, Dr. Athiya, right? Gram is bigger, it's milligram dose. Dose has to be correct for your patient's safety. 3 milligram levonorgestrel for enzyme inducers, but it's absolutely contraindicated. Now, there can be a station in which breastfeeding mother is there, Dr. Athiya. It can be a station, right? That she has come that I'm breastfeeding. Again, in breastfeeding, these 2 can be given. Ulipristal acetate in a breastfeeding mom cannot be given. Or you tell her that at least for 7 days, you have to avoid breastfeeding. Am I clear? What do? They put the patient with a previous history of PID. Then your first option would be these 2. It's not that you're not going to tell about copper coil. You will tell about thrice of them like Dr. Athiya did in this station. But then you're going to tell her that what are the changes which you're going to do. So all these contraindications should be on your tips because they can put in any one thing, either enzyme inducer, either raised BMI, either a PID, so that you should be knowing. There can be a station where asthmatic patient is there, she wants emergency contraception and she's taking corticosteroids. So you cannot give ulipristal acetate. There can be a station in which she's taking omeprazole or ranitidine. Specifically, this table I've taken from FSRH, friends, FSRH emergency contraception. Okay, for you guys, so that on your template, you write down the contraindications because in exam, if they give some contraindications, you know that they are checking us on this thing, that how we basically change our management plan according to the 3 available options. Am I clear? Right? Midhat has a question. Should I tell her that this will not prevent pregnancy with further unprotected sexual intercourse, pregnancy test after 2 weeks? Yes, Midhat. As Dr. Athiya said, that if you don't have periods, we are going to test you for the pregnancy test because the failure chance, Midhat, is always there. Right? Now, my requirement is that you all note down these contraindications into your emergency contraception template so that if any question comes, you're going to just change these, switch over 1, 2, and 3 according to the contraindications. Now, for all these emergency contraceptions, what you would do is that you would tell her all thrice of them, mechanism of action, and the recommended dose. That's it. That would be the first 30 seconds of your management. First 30 seconds of the management, as Dr. Athiya did, that was correct. Please don't forget the doses. It's 1.5 milligram single oral dose, 30 milligram single oral dose, and the copper coil, you know, that needs an insertion, right? Now this table you don't need to do, but I've brought it just for this reason so that you don't forget. Why? To tell you this part. Can you all see here? Can you all see here? BMI more than 26 kilogram per meter square and weight is more than 70 kilogram. This is again FSRH recommendation. Now, I'm sure you people will not forget forever that if weight is, I purposely said 73. When weight is more than 70 kilogram and BMI is more than 26 kilogram per meter square, you need to double the dose. Am I clear, everyone? You just need to remember that you need to double the dose for the levonorgestrel. That's why I've placed this table here, so that I want that your memory is better and everything we are discussing here that actually comes into your mind in the exams day. Okay? Clear, everyone? That from where did I take that? Dr. Athiya, is it clear? Very good, Nadra. Great. So that's it's written. that 3 milligram of levonorgestrel you have to give for this, okay? Otherwise, these tables are for part 2. You need not do that. Some important points in applied clinical knowledge, which I wanted to discuss for this station, is that if it's less than 14 days, yes, you can give the oral pills. Total, if she asks for that, what is the most effective method, you will say copper coil. If she asks for about the older pills, what is better, your answer would be ELA1 if it's not contraindicated. And you should be knowing for 5 days you can give, 72 hours you can give for levonorgestrel. Now, it can be taken even after 72 hours, but again, the failure chances is more. And again, if out of these two, patient asks that what is better for me, you say that the chances of success are more with ELA1. However, whatever suits you best, because you fall into the criteria of being in 3 days time for the Levonel as well. But if she comes to you in an exam station, generally they give you less than 14 days. Why? Because all the 3 are applicable there. But if they give you after 14 days, please don't make a mistake of just giving copper coil. Your applied clinical knowledge goes fail. You will tell thrice of them and then say, because we anticipate that the the egg release has been done, therefore suitable option is copper coil. But offering thrice of them is important. Am I clear? Students, when they do this station with me, they immediately after 14 days, they say the emergency contraception available is copper coil. And in applied clinical knowledge, see, emergency contraceptions are 3. You have to offer thrice of them and say that because the mid-cycle has passed, therefore the chances of the egg release is that it's been done. Therefore, the failure of the oral pills, it's going to be more. It is suggested that copper coil is inserted after the mid-cycle date has passed. Am I clear, Isla? Did you people understand that how you're going to do rather than just telling about the copper coil in the second half? Okay, but generally if you see all the stations, important stations, you'll understand that they give the first 14 days with some sort of contraindication or cautious use rather than doubling the dose or BMI or enzyme inducer. This is how this station, it comes in exam. Introduction, agenda making, information gathering, evidence-based management option you will have to make. Then what option suits her best? Address her concerns if she has any. Come to a mutually agreed plan. Follow her up with the pregnancy test if periods are missed. Follow her up with another sitting of an ongoing contraception plan. This would be your last line. And don't send her back without doing the emergency contraception prescription today. Right? These were slide points. Very well done, Dr. Athiya, for the 2 domains, perfect. And the other 2 domains, I'm happy that you did mistakes today so that in exam it would be perfect, my dear. Any questions, please, regarding the first station? I'm open to the questions, yeah. Okay, yep. Emergency contraception, I tried to cover it from all angles, but still, if anything is not clear, please let me know.
Yeah, Dr. Sidra, I have 2 questions.
Sure, please, yeah.
One is, in this station, we can offer her ulipristal acetate, right?
BMI has nothing to do with that. Yes, you can offer.
Okay.
Either double dose levonorgestrel or 30, the 1 single dose of ulipristal acetate. That's
so we
fine.
can tell her that it is seen that it is more effective. So
both are effective. If you double the dose, that's fine. And if she
Okay.
wants that out of this, what I can take, she's in the safe time period at the moment. She can take both. Yes. Whatever she's comfortable with. She did not have any contraindication to ulipristal.
And the
So
second,
how we will decide, doctor, to give which one? Like we will all say that Levonel we will give double dose, or we will give her option to decide
If
between
you
the
decide
11
for
and.
first, if you want to take the Levonel, we will double the dose for you and prescribe it today. And if you're happy with ELA1, we can prescribe you that as well. Whatever you're comfortable with, Isla.
Okay.
So basically it's her choice out of the pills. The first thing is that she's not happy with the coil. So after explaining coil, come to the pills again. Now, out of pills, it's her choice, whatever she, as I said that I want Levonel. So it's fine. Basically, it's easily available as compared to this, you know, and people are comfortable with that. That's more used. But still, if she wants ELA1, you give her ELA1. That's okay if it's not contraindicated because she is in the same time period, less than 14 days. That was all right. Closure, Bindu.
Hello.
Thank you for speaking to me. Yeah, let me answer Bindu's question. I'll come to your question. Bindu, you'll just say to her that I'm right here waiting for your response. And if she doesn't ask time and she's ready for that, give her the emergency contraception, tell her about the vomiting thing, and say, thank you for speaking to me. If at all she doesn't have periods, she has to follow you up with the pregnancy test.
Okay, thank you.
So this is how you're going to do the closure for this, and also tell her about the ongoing contraception plan sitting. So in the next sitting, if I can fix an appointment, we can discuss the ongoing contraception, if that's all right with you, Islam. So thank you for your time, Islam. Okay. Liana, just if whatever she desires for, then tell about those. If everything fits in her, Liana, like Levonel fits, ulipristal acetate fits, and also the contraception copper coil. So then, of course, whatever she decides for, you should tell about its side effects, of course. Like if she agrees for the copper coil, you would say that it might cause heavy bleeding, vaginal discharge, the chances of having infection is more with that. So, but it is a long-term contraception as well. So you give its pros and cons, like one pros and one con, whatever she decides for. Okay, right? Yes, I had some questions. The mic was on mute, please.
Yeah, another scenario where if suppose we examine her on speculum, if we see discharge, so we are suspecting STI there,
Send
and
it, swab.
and if she is more than 2 weeks from her LMP, then do we give prophylactic antibiotics and put the coil and then wait for the swab report, or
No, you give the antibiotic and you send the swab, you wait for its report, you insert the coil, and you put her on antibiotics, and you tell her that the chances of infection are more. However, risk versus benefit you have to weigh there. One is that she would come up with unwanted pregnancy, right?
Because coil would be more effective in her case than the pills.
So the coil, of course, the choice is on the coil because the ovulation date has passed, right? So you cover up with antibiotics there. This is your safety. And send the swab. This is your safety.
Okay, thank you.
Okay, right, welcome. Yes, Nadra, when she'll ask that what is more effective, you say that Ella1 is effective. As I told you about the 98 out of 100, the success rate, right? Okay.
One more thing, doctors.
Yes, my dear, please.
Yeah, you told that after 14 days, if we are talking about, obviously the option is only IUCD, but we will tell about the other two also.
Why?
Yeah,
because
so
clinical knowledge goes failed there.
Yeah,
so you have to tell that we have got 3 options. What suits you best in this situation is this.
So no, when we are talking about tablets, so we will say just one liner thing. Both of them act by preventing the ovulation. That's all.
Yes, my way was only I used to keep them together rather than first telling about one mechanism, then second, then it wastes time. So the pills, they work as inhibiting the egg release, preventing the egg release. So, you know, your job is done, that both they're together because they don't have difference in the mechanism of action.
And we don't need to go in detail because it is not the option for her as it is already post-ovulated.
Exactly. You say that because the egg release has been done according to your cycle date, so the preferred option. However, Sarwat, generally if you see the question, they're almost always less than 14. Because, you know, they want you to discuss all and then choose the best. But still, you should be knowing. For your applied clinical knowledge, you should be knowing. We should be ready for all the angles, you know, that if they twist this, that's why I gave you the contraindication table, that if you put it on your template, that means that whatsoever angle they are testing you for emergency contraception, you should be knowing that, okay, this is the twist, right?
Yes.
Okay. Thank you very much. Thank you. Do we have to take swab in each patient before putting? Yes, it's done, Dipti. It is preferred that we do that. Sending the swabs before copper coil, it's a patient safety. Yes. But giving antibiotic only when you see discharge. In symptomatic patient, you give prophylactic antibiotic. Okay, Dipti? Not in all patients, antibiotic before copper coil is not recommended, but in discharged patients, we do give the ones who have evident vaginal discharge. Yes, please. I had some mic on mute. Yeah.
Dr. Sidra, I would like to. Should I tell her about the side effects of the pills? That there may be vomiting, or it's not important to mention this?
No, this is important. Dr. Athiya did touch about that vomiting and all, yeah, and she asked me to repeat the dose where I asked about the dose as well. So do
Dr. Sidra, how this sending swab before copper coil for everyone, whichever patient comes?
Especially less than 25, it is recommended because less than 25, the guideline says that they are high risk for STDs. Elderly, married women, it's fine. It's not required. But less than 25, we always send the swabs. Okay. Sending swabs is a patient safety less than 25 to rule out STDs. 25 is the cutoff for the high risk STD patients less than 25. Okay.
Yes. Okay.
Any other question from emergency contraception? I wanted to do this station first because this is going to be applied in many other stations today, like 2, 3. This would be part of that. So a wonderful start, Dr. Athiya. I would like you all to give an applause because to start off, it was a very good station in terms of tone, in terms of communication, in terms of talking to Isla being a young age patient. I was very comfortable talking to her. So this was a very good start. And I'm sure we are going to work on these things. Anybody would have been here would have missed these points. So whenever you're on the hot seat, yes, you feel hot. So it's absolutely okay. Thumbs up, Dr. Athiya. Well done. So we'll keep on working on the points which we have to improve for the exam. Thank you very much. Thank you. Clap, 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 Girija. Thank you very much. Okay, let us move to the second station. Are we all ready?
Thank you for encouragement.
Thank you very much. We'll do perfect again as well. Just make these points in your template so that any twist comes, we would be perfect in that. Thank you. Okay, so lots of appreciation, Dr. Athiya. Very confident. Yes, she's very confident, and that's a good part. And okay, so let's begin with the station number 2. Jyoti, can we check your mic?
Yes, I'm here, Dr. Sidra.
Hello, how are you?
I'm fine. How are you?
I'm good. Thank you very much. So today you've got night call, right?
Yeah.
Let's do a station and I'll start your 2 minutes time. Let me fix my timer.
Just
So,
nervous.
3, 2, 1, go ahead.
Next page.
Yes, Jyoti.
Hello, can I start?
Yes, please.
Hi, I'm Dr. Jyoti, one of the doctors in the clinic today. May I confirm your name and age, please?
So, hi, Doctor. I'm Ella James. I'm 18 years.
Hi, Ella. Is it okay to call you Ella?
Yeah.
Ella, I understand from the letter I have here from the SARC, that is the clinic, sexual assault clinic, that you have come here for a management plan. I'm really sorry for what has happened to you, and I know I can't even begin to understand how horrified, humiliated, and traumatized you must be feeling. Will you be able to talk to me about it?
Yes, Doctor.
How have you been coping?
Yeah, I'm trying to forget it, doctor. I'm trying to move forward.
Yes, I know it is very traumatizing for you, and you might be feeling embarrassed to speak, but I assure you that you are in a safe place at the moment. And I would also assure you confidentiality, unless I have to break it for purposes that would be for your safety and well-being. Will that be okay, Ella?
Okay.
So Ella, what have you been doing? Have you been have you been able to resume your normal life and thoughts?
Yeah, I've been trying that, doctor.
Okay. Will you be able to talk and let me know what exactly happened, where it happened, and with whom?
Yeah, doctor, I was at a friend's party and there were multiple people out there. I don't know. We were just having an enjoyment. It was suddenly that a group of people, there were like 5 or 6, they just came towards me and they assaulted me.
I'm really sorry, Ella. So are you able to have understanding? I mean, able to talk, able to understand what I'm saying, and able to get the information and able to talk to me with an understanding? It must be really, your mind and thoughts must be really clouded, and that is the reason I'm asking you this.
No, I'm fine. Yeah.
Okay. And if I'm not wrong, this happened 2 days ago.
Yeah, 2 days back just.
Okay. And have you informed the police?
I went to Cirque and I think they've informed the police here.
Okay. And do you know the person?
I don't know them at all. They were new to me.
Okay. And this happened at your friend's place?
Yeah, there was a party in the club.
Okay, okay. And does anyone else know about it? You were there with your friends?
Yeah, lots of friends were there, around 30 or 40. Gathering was there, and 5 to 6 they came to me and assaulted me. I didn't tell anybody. I just informed the Cirque, and they informed police as well. They took few samples from me day before yesterday, and they just sent me to you to talk to you.
Okay. And were you under the effect of any alcohol or a drug at that time?
No.
And what about the assaulters? Were they under the effect of any drug or alcohol? Would you know that?
I don't know that.
Okay. And sorry, just a minute. And are you in any pain at the moment? Any physical pain?
I hear my arms, they are hurt. I've got some bites at the arms and the legs, yeah.
I'm so sorry. Do you need any painkillers before we can continue?
I've just taken that, thank you.
Okay. And has anybody examined you for your injuries?
Yes, they did that in the Cirque.
Okay. And they have they noted down everything on the on paper?
Yes, yeah, some people, they took all the samples as well, doctor.
Okay. So let me tell you, Ella, that the whatever they have recorded is in your own words, and that would serve as a legal document just in case you need to go further on this. And I just wanted to know, who do you live with? Do you have enough family support?
Yeah, I live with my parents. Nobody knows, but yes, they're very supportive otherwise.
You haven't been able to tell this to them?
No, I didn't. I was not comfortable telling it to anyone.
Okay, okay, I understand that. Okay, let me ask you a little about your, do you have any medical illnesses at all?
No.
And do you have any allergies?
No.
Okay. And do you smoke or take alcohol?
No, doctor.
Okay. And also wanted to know whether they have taken swabs and they have collected material from you. I think you said that they have.
Yeah.
Okay. And have you given a urine sample, mouth swabs?
Yeah.
Okay. And what would you need to, is there anything that I can do to make you more comfortable? Anything, any concern at the moment to make you comfortable or to do anything for you?
No, actually they just said that I need some treatment. That's why I'm here for.
Okay, okay. Yeah, so I will, if I can examine you, if you're okay with that, can I examine you in the presence of a chaperone?
Sure.
Okay. So, okay, I will look at your injuries, and I will, from the swabs that they have taken, I think it will come only after a few days, after 3 days. But I would need to give you emergency contraception because you definitely don't want to get pregnant, do you?
No. They give me emergency contraception. They gave me a pill.
Okay. Okay. And can you, sorry, I should have asked you this before. Can you describe the whole, like, was it penetration or was it less than that?
Yeah, that was penetration, all oral, vaginal, back passage. Yeah.
Okay. And what about your, have they started you on any tablets to prevent HIV infection? Because that is a definite risk. Because
No,
we don't know
nothing.
what.
Just emergency contraception and samples were taken. That's it, doctor.
Okay. Do you have any history of any sexually transmitted disease in the past?
No, doctor.
Okay. So we will wait for the swabs to come. And if there's anything after 2 weeks, we will do a swabs again to see if there's any sexually transmitted diseases which has happened. And then we will give you treatment for that. They can be chlamydia or gonorrhea, but we will know that only after 14 days from the day of the event, the day of the happening. Is that okay?
So I don't need any antibiotic at the moment, doctor.
Yes, we will give you antibiotic as a prophylaxis, so that it is prevented. So we will, definitely will give you some antibiotic to prevent any sexually transmitted infection. Is that okay?
Yeah, that's okay.
And I will also give you something for pain, which is, you said your arms and legs were hurting. So I'll give you something for pain. We will chase up the reports, chase up the swabs which has been taken for you, and see what comes out of it. We will also have to do a HIV test and a hepatitis B test and a syphilis test after 3 months to cover for the window period, because sometimes it is not evident at that time. But we have taken a baseline bloods for you. And we will check it again after 3 months, just in case there has been any transmission if the person was, suppose, HIV positive. I'm sorry to talk about all this. Am I scaring you? Sorry about that.
No, it's.
And I would also like you to meet a psychologist so that you're able to sort of get out of this trauma. Is that okay?
That's okay, doctor.
Do you like that?
Like it. Yeah.
Okay, so I will do that. And also we will give you follow-up appointments with the psychologist so that you're able to cope with any post-traumatic stress disorder that you can, I mean, sometimes you have flashbacks of these unpleasant memories. So just to prevent that from happening, and so that you can continue with your life without having bad memories of this experience. So that will help you out. And Ella, feel free to talk to me whenever you want to. And do you have any concerns, any other concerns at the moment?
No, doctor, it's okay. Thank you.
All right. Thank you.
Welcome. Difficult station, Jyoti, yeah?
And no, I mean, it was when she comes immediately, then that was good enough. But this was 2 days later, so I don't know what all has been done for her already. It was
So I told you on the emergency contraception samples have done, right?
Yeah.
So a lot had to be done as well, no? Okay, how did it go? Tell me. Yeah.
I think I've missed out on many points.
Tell me the good points first, okay?
I don't know.
Oh, don't say so. What were the good points?
STI screening they had done already, and she has gone to
Very beautiful start with empathy.
Okay, very
Yeah,
good.
very good tone with the 18 years old. A very good tone, actually. Sympathetic.
Okay. So Jyoti, people are loving with the tone of yours. So other than that, let me know that what good things you think you did in the station. Yes, Dr. Athiya, what were the good points she did? And tell me the points to improve as well. Short empathy. Yes, Bindu, she did tell. Yes, Ramya, tone was good. It was an empathetic tone, yeah. Okay. Yeah, she's good in communication. I agree. Yeah. And right. Okay. Points to improve. Yeah. The things which you think that that could have been better, or the things which you think that where I could have spoken a little more. And yeah.
Yeah, so I did touch on the post-exposure prophylaxis of HIV. I told that I would give her prophylaxis for HIV because we don't know whether the person had HIV.
That's fine, yeah. Okay, tell me about the history. Was history in a sequence? Wasn't it a little up and down today?
Very haphazard, yeah, it was very haphazard.
So
I kept forgetting a few things and coming back to it.
Yeah, so especially even if after examination, you came back to the penetration, you came back to the STIs, you came back to the, and mental history was missing, which is never to be missed in this type of station, right? Because this is
how are you feeling now?
Yeah, the talk article says that they have suicidal tendency. I'll give you lines on that, but that is something really important that had to be spoken up, right? I was expecting that. Group B, please be active in the chat box. Salma, Al-Sabai, Nada, all of you, please. Dalia, Midhat. So any queries, please do give your comments. I'm waiting for the chat box comments, right? Okay. Now, introduction, as people said that it went all right. If I tell you that introduction, you yes, that was good. But if I would have been at your place, I would not have mentioned the word referral from the sexual assault referral center, the SARC. The word I would not mention. So it was good that you didn't make an agenda saying this. She was Ella, right? So I would have been starting this like, Ella, I'm aware of the unfortunate event you've been through. I'm here to listen to you and support you in this situation. I'm sorry I had to meet you in this difficult situation, Ella. So I would not tell her that I know I have received the sexual assault.
Can you repeat that, please?
Yeah, I will do that. Ella, I'm aware of the unfortunate event you have been through. I'm here to listen to you and support you. I'm sorry I have to meet you in this difficult situation, Ella. I'm sorry taking again will bring back the bad memories, but I need to ask a few questions to know more about you so that I can give you a proper management plan. Would that be okay, Ella? These would be my first few starting lines without mentioning the word sexual assault. Right? I would not mention sexual assault at all.
Yeah, I didn't want to mention it, but I had no other, I couldn't formulate any other way to do it. So that's why I mentioned it.
Just cram up these 3-4 lines in the beginning and come to the information gathering, right? And come to the information gathering. So these 3-4 lines you all have to write on your notes and just mug it up, okay? And try to speak it in an empathetic manner. Then my first question would be, how are you coping after this event? So how are you coping is the general well-being question. See, my HOPI is very organized for this station. First is being general well-being. That did you tell anyone, right? Then I would ask about the symptoms. Why, Jyoti, she's here after an assault. So the pain and the vaginal discharge, fever, hurt and bruise would come earlier. Let me go to this side by side so that I can tell you how I made the information gathering. Communication with the patient and the relatives in this domain, I have given you around one, just because of few reasons. I'll give you my clarification for that. Just because that the communication at times was a little more like the words used, like you might feel embarrassed talking about this. I would avoid this. I would avoid using the word sexual assault at the top. So these two made me a little, as a role player, a little taken aback, right? So this communication, greeting was fine, introduction was all right. Consent to proceed and explaining the nature of the interview was fine. Don't mention the word about the sexual assault in the beginning. Yes, you were an attentive listener. You were trying to make me feel better. However, it was taking too much of time. History taking was in a sensitive manner. However, I would like it to be a little more organized. History of presenting illness, I would start with, how are you coping? Did you tell anyone? This is the first part of the history of presenting illness. After you introduce yourself, come to the history after signposting. Did you tell anyone? May I know that do you have any pain, vaginal discharge, fever, any hurt or bruise? Ella, could you please tell me what actually happened? How many were they? How did they look like? Was it actual penetration, oral, vaginal, or back passage? Were they known to you? This would be my third part of HOPI, in which I would like to know about the details. So first would be her well-being, starting with how she coping. Second would be her symptoms. Third would be the details of this detail came, Jyoti, after examination. This is the first thing that you need to know, which type of assault it was.
Dr. Sidra? Dr. Sidra, do you think we should not bring up ethnicity right here, right now?
That's important. Why? Because the talk says that this helps the police to know that what the clue, that how did they look like. I would not mention the word ethnicity. How did they look like? That's very important, because there's certain groups, they're working on this, and this information gives them a clue that which type of group of people they are, which are doing the assault.
Then we would be stereotyping the ethnicities, right?
So this is what we need to know, is how did they look like?
All right.
So this one question you need to ask, right? So were they known to you? Were they known to you? Then come to the contraception history. Are you practicing any contraception at the moment? Any long-term contraception? May I know your current day of the cycle? Any emergency contraception taken? Because she has passed 2 days. If not, you will put it in the management plan. So up till here, till 6th point, it would be your HOPI. So starting again, that Ella, I'm aware of the unfortunate event you have been through. I'm here to listen to you, and I'm sorry that I had to meet you in this difficult situation. I'm sorry, asking questions would take you back to the bad memories, but I need to know to formulate a management plan for you. Can I ask you questions? How are you coping with the situation? Did you tell anyone? So up till now, I've not mentioned the word assault at all, right? Up till now, I've not mentioned the assault at all.
Yeah, I didn't want to mention, but then I
understand. I respect
not to mention it.
Yeah, now you just note it down and just mug it up, okay? No problem. So do you have any pain, vaginal discharge, fever, hurt, and bruise? I want this all to be in a smooth continuity, friends. It would come with the practice. That yes, okay, this part is done. General well-being is done. I'm coming to the symptoms now. Sexual assault details now. Then her contraception history. Then menstrual history. Then emergency contraception. Now my HOPI is done. Now, if she's elderly, you can ask about the smear and everything. And if it's if gynae history is not applicable here, you can skip that. So any pregnancies in the past? May I know that do you have any problem like clots in the legs, any migraine, asthma, or liver problems? Any family history of concern you would like to tell me? Any surgery in the past in the tummy or down below? Any allergy of drugs or metals? I would like to know about your height to weight ratio. Do you smoke, drink alcohol, or pardon me to ask about recreational drugs? Coming to the support, you did ask about whom do you live with and has the support at home. But mental history, you don't have to skip. Your information gathering goes failing if you don't touch this point, friends. Why? Because mental history, the talk article says that after assault, there is a lot of depression, even suicidal ideation. So what I would say is, Ella, I can understand it's a difficult situation, feeling as depressed or tearfulness to the extent that suicidal thoughts are there, and we encounter many patients. May I know that how do you feel after the event, or would you like to have some support? So when you say the suicidal ideation, you're trying to make her come to this situation that if she wants to tell you that, yes, doctor, I'm having these thoughts, then this advocates for the admission of the patient. You're not going to send her back home, right? So mental history, again, you can say, I can understand that it's a difficult situation. We see patients who feel depressed, tearful, to the extent that they have suicidal ideations. I know it is a personal question, but I would like to know about this if you require support. Right, Bindu? This is how I would speak about the mental health, not saying that you have suicidal ideation. We see patients who have depression, tearfulness to the extent that they have suicidal ideation. Clear? So basically, it's making her feel that it's not something happening with her. We see patients like this, so please come up with your ideas. Right, Bindu? This is an ideal way to make her know that had the mental health. Basically, she has to come up with. Great. Now, you did examine, but what happened in the examination was that after examination, you came back to the, again, history, the penetration and STIs, right? So I would examine her by saying that, yes, I need to examine the height and weight ratio, and with a small device to see the vaginal discharge. If it's there, we are going to send the swabs. If they're already taken, you will say that we are going to change the reports. That's fine. Investigation was sending swabs. If it's done earlier, that's okay. If not, you can do that today, right?
She told me that it has been done.
So you're just going to follow the report. That's fine. Now, once you came to the management plan, I did not find an organized management plan, Jyoti. Yeah. Patient safety was almost done. Emergency contraception she had done earlier. You were very sensitive and you were actually dealing her with dignity. You ruled out sexually shared infection. These points were all right, but giving her the right management plan is very important. I was waiting for that. Remember, the first thing which you have to ensure in the sexual assault patient as a management plan is that the patient thinks that she is safe. So now coming to the management, and I told you characteristically somewhere in between that SARC has sent me to you because you need to give me some management options, right? So the first thing you need to remember is that, Ella, do you consider yourself safe going back home? Or else, if you wish, we can admit you as well. So she says, yes, this is your first part of the management, that you should know that she is safe. If emergency contraception had been done, that's all right. If it is not being done, you will give her the option 3 and you can give her pill right away according to the situation. Here, you would say, as you had already been given the emergency contraception, I would like to discuss some ongoing contraception plan with you. And if after 2 to 3 weeks you do not have periods, we would like to perform the pregnancy test. Would that be okay? Right? Now, Ella, according to the situation, as we are not aware about the HIV status of the assaulters, therefore, it is suggested that we start you with the post-exposure HIV prophylaxis today. Along with that, I would like to give you hepatitis B vaccination. This vaccination would be started as the first day today, if you're all right with that. Now, antibiotic we give to prevent the sexually shared infection. We would also follow the reports and alter the antibiotic if required. As you are saying that you've got some sort of bites and wounds on the arms and the legs, I would like to cover that with antibiotic as well. Along with that, would like to give you tetanus injection today. Are you all right with all these? I would also like to tell you that after this is done, we are going to follow you up after 1 week for the second dose of hepatitis B, and after 3 weeks from today for the third dose of hepatitis B, as we are giving the first dose today. After 4 weeks, I will call you for the HIV testing. And at 3 months, we will again do the sexually shared infection, if at all there's some infection found. So the follow-up is very important. First, 0, 1, and 3, that is for the hepatitis B. 4 weeks according to the TOG article, that is for HIV. And at 3 months again for the sexually shared infection. This follow-up after this management plan has to be done. Basically,
Doctor, we have to give hepatitis immunoglobulin.
Vaccination.
Only vaccination.
Only vaccination. As per TOG article, only vaccination. Another thing which I would like to tell you is that this tetanus as an antibiotic is not for every sexual assault. Only if in history she says that I've got human bites and, wounds. Clear? This is not for every sexual assault. This you will skip if the patient says that, no, I don't have any wound, I don't have any sort of, she doesn't tell you about the human bites. Where she tells you, when you ask about the symptoms, that do you have any pain, vaginal discharge, fever, hurt and bruise? That's why I keep this question there, so that when she says hurt and bruise, you come to know in management, are you going to put tetanus or not? Am I clear? That's why I formulate that question there. Otherwise, it might have been missed. If it's not there, then tetanus antibiotic is not required. Clear? And this antibiotic for chlamydia has to be given. I found you a little shaky, Jyoti. You were saying that after 14 days, we'll start. So it is an assault. We have to give antibiotic for the chlamydia gonorrhea. Okay? And hepatitis B vaccination, you had to tell about that. You checked for the infection. You didn't give the vaccination. You had to give that. Post-exposure HIV prophylaxis, you did that. Emergency contraception, check about the safety. So go in this organized manner, 1, 2, 3, 4, 5, 6. And believe me, if you just cram it and make a good flow, it takes not more than 1 minute to give this management plan. Only 1 minute. And your applied clinical knowledge is passing, right? So divide your stations. I always make the outline. So divide your station into parts. Introduction and agenda, 2 minutes, done. You come to the information gathering. It's a little slower in this case because we are talking to an assault patient. It might take around 3.5 minutes. That's fine. So around 4.5 minutes, you'll be coming to the management plan. You'll address her concerns. It will take around 2.5 minutes. You tell her about follow-up. That would be another taking maybe some 40 seconds or something. And in the end, you give her the support like Women Aid. Please do mention the support group. That is the Women Aid, and tell her about that the social counselor services. Jyoti did connect me to that. You can ring the clinic or you can drop in whenever you need to ask something. So here it is going to end up with this. Not today, Dua. Dua, not today. We'll fix an appointment for the ongoing contraception for her. So we'll discuss in the next sitting. But you have to mention this point. So later, in the follow-ups, we can discuss the ongoing contraception plan as well, if you're all right with that. So this is how you go with that dua. Just mention that. Not going to do that today. Okay? We just mentioned that after she has these periods, so we can do that ongoing contraception so that she's safe. Yes, Fawzia, gum referral, you can mention in the STD follow-up as well. So we are going to refer to the gum clinic so that the sexually shared infections, they are treated if at all, if they're there, or you have a follow-up there as well. You can mention that. Okay? Now, am I clear about sexual assault? Any question? Just follow this pattern and be smooth in your management plan. Just follow the information gathering in this manner of HOPI, one after the other. Wonderfully, questions should be coming one after the other. So, you know that, okay, this is my 1, 2, 3, 4, 5, 6. Okay, my job is done. HOPI done. Just complete the template. This is done. I have to come to the examination investigation. It is done. Now, coming to the management plan, I have to go with the ensurety of being safe, emergency contraception, HIV, hepatitis B, antibiotics, tetanus, and antibiotic to cover those wounds if required. It's done. I will tell her about the follow-up, give her support group and PIL. Always remember, do your checklist in your mind that, okay, this is done, I'm moving to the next. This comes with what? This comes with practice, that you know your parts of the station. Okay, first 2 parts are done. Have a smooth information gathering. 5 minutes are done. Okay, next 5 minutes, I need to pass this station. Be organized. Tell the management plan in a 1, 2, 3, 4 sequential manner without fumbling. And you tend to manage this station, right? You can admit her, Fawzia. If she says that she's not safe to go home.
Doctor, closing is the like same all others, like this is the written information. I will connect you with the support group.
Yes, yes. And
It's
women
the same,
it
yeah.
is a very important support group. You should mention that. The important support groups you can mention, right? Whether can we ask about whether she's sexually active about the partner? Ramya, when she asked about my contraception, I think I told about the being condoms used and no other emergency contraception in the cycle. So did you inform anyone? Jyoti did ask me. I said I didn't inform anyone. So that's all right, okay? So you simply ask about the emergency contraception, that do you take any contraception otherwise? So that's one question which is going to give you a clue about the partner. Dua, not completely woolly questions. Why woolly questions are not to be done? Because this is not a state of postpartum depression or antenatal depression. But here you need to take out the suicidal ideation. In woolly questions, suicidal ideation is not there, right? So the talk article says that these patients at times they have this ideation, depression to the extent that they want to kill themselves. If that's there and you pick it up, you're going to refer to the mental health team immediately and you're going to admit this patient. You're not going to send her back. If she says that, yes, I'm so disturbed that I feel like ending up my life. Now she won't tell you herself. You need to dig it out. That is the reason I made you, gave you those lines that I know this is a difficult situation and we see different patients who are depressed and tearful to the extent that they have their suicidal thoughts. So may I know, do you require support in that condition? So basically, you know, she would be coming up with like, okay, many other patients, they talk the same dua. So you can help her with this. Claire, everyone, I know it was a tough station and being a role player for sexual assault is also very tough, but there were many good points. If I do the marking, information gathering, I would like Jyoti to be a little more fluent next time. Just work on that. Next station, information gathering is going to be your test, that it has to be perfect. I gave you borderline 1 in information gathering. Apply clinical knowledge. I just came to know about the HIV thing. So it was around 0.5. Communication with the patient, I'm happy with your tone. It's around 1.5. That is almost passing. And patient safety, again, because not giving the right management plan. So it would be around borderline as well. But communication with the patient is one domain which is passing, right? And I'm sure in the coming stations, we would work upon this. Be very good in information gathering. I want all my students to be perfect in information gathering. One after the other, questions should be coming like spontaneously because it's in our hands. It's something which we can practice and we can do in an easy manner. Okay, all of you. Any questions regarding sexual assault?
Yeah, yes, I have a
question. Yes, please. Yes, Dr. Sabia. Glad to listen to your voice. Yeah.
Dr. Sidra, this patient referred from SAR. Okay, the situation is different. When the patient's coming directly to you, middle of the night, in the ER or during the day, then what will be the sequence?
Okay, so what you'll do, the difference would be, Dr. Sabia, that you'll refer for the sampling and all, you'll connect to the forensic team and you'll call them. So their job is to take the samples, not yours. So the only difference is that there you are going to call the special people who are going to take the samples and do the forensic part. And if she's okay with that, if she wants police involvement as well, you're going to inform that. But your management plan would be the same. Your management plan, this is your domain, like hepatitis B, HIV, giving antibiotic, giving post-exposure prophylaxis, emergency contraception, you would do. The initial part, you're going to involve that specialized team who is going to send sample and investigate. You would just say this line. And they will take samples from different areas and to investigate further. This would be your part in that.
So we will take her swab for STI also?
Yes.
Or we will refer her to the...
No, STI swab, you can do the forensic samples, you know, all those sorts of forensic samples. They take hair samples as well. They take few from the vaginal route as well and the back passage. That's fine, right?
Okay.
Okay, this is so that's what I'm saying, Ramya. those forensic people, they would be doing that, because then they have to evaluate that as well. Okay? So you can simply say that you're going to involve other people for your safety to send the samples for the investigation, and we will follow you for that. Right?
In this station which you did, which was already referred from the SARC, so in this we have to repeat the things that have you been given the emergency contraception, have you been taken the swab. We have to repeat it, or it's already understood that as she referred by the SARC, no need to mention.
Yeah, so you know what happens is that at times, okay, can you all hear my voice? Okay, so at times what happens is the students who don't make an exam, they don't target the domains. They don't understand the template. Why do I emphasize on that? I sent all of you a sample template. The templates in which I have my watermark of 1-to-1 stations, that is the template which I check off students, because in the previous batches I used to check their homeworks and to make their final templates. Why? Because see, it makes your things easy. In exam, after last 2 months, you just revise those things and you speak it up. If you are going to see that, you know, like for instance, Jyoti doesn't have any problem regarding understanding the system because she's working in UK, right? She knows everything. But the idea is, I've got one of my student, Krish, and he's an ST4 at the moment. He was with me in part 2 as well. Now, the problem with Krish is that when he takes the history, he takes as if he's taking in the clinic. And I always tell him, like, Krish, please, squeeze it up. Don't think that you've got entire day to talk this patient. You have to target your management plan. You have to target your domains. You've got 10 minutes. The points should be in your mind that I have to speak it up. Okay, one after the other. It should be coming one after the other. Yes, Fawzia? So when you are lost in your communication, so you forget that other domains are also there. Like communication with the patient, Jyoti has passed. But she needed to discuss the management options because they are a separate domain. So you all understand my point? That how you have to keep your template in mind that I've got a lot to cover. So let's move forward. So always think of your domains. Okay, very good. So we can take swap before forensic samples. Yes, we can do that. We can do that. Okay, Dr. Sabia, I'll get back to you after the session, okay? Yeah.
Dr. Sidra, I have just one short, small question.
Please, my dear, always welcome, yeah.
So I just wanted to know that you said that do you feel to say to me after 2 days? So I assume that she's coming from home because I said, who do you live with? So how do you tackle that?
So you can simply say that, do you feel, now it's your responsibility now, you are seeing her for the first time after the event, right? So now you're sending her back home. So now it is your patient safety. That now, do you feel safe going back home? So if she says yes, your safety is done. If she says no, doctor, I'm having lots of thoughts and I think the people would be trying to contact me or something as well. So please, you know, something like that. That means that your question was valid. She might come up with something like, doctor, I'm not safe, right? So you're seeing for the first time, no matter she's coming back from home, and if she had been receiving some threats, now it's your safety that you ask this question, that do you feel safe going back home? Okay?
Okay, understood.
Okay, thank you very much, Jyoti. Keep going, Jyoti. I'm really happy with your tone always. You're very good in your communication. Just work on your bullet points on management, tuck, one after the other, okay? And also work on your sequence of information gathering and speed it up. Like you're on duty, do it like for 3 minutes and say, okay, what did I miss? 3 minutes, 4 minutes information gathering, one after the other. Your questions should be like in your mind. Just link up the questions because we've got less time and we have to cover it up in a smooth manner, because the first impression in the 3 to 4 minutes is that should be very good in the examiner, that okay, information gathering is something which we can improve with practice, so why not to do that? All right, and I'll give you information gathering HOPIs of every station so that you can work on that and just cram it up and go in a good sequence and a good flow. All right, well done, my dear. Well, thank you very much. Okay, Nadra has a question here. If she comes in emergency for the pain, has received the EC antibiotic, Pepsi 8-1, the TARC or police involvement, is it patient's choice or no? No, Nadra, you have to involve police because investigation has to be done. Okay, because it's patient safety. Generally, she doesn't do that, but still you say that's for your safety. Your confidentiality would be maintained as you're talking to me, similar to them. But this is for safety, your safety, and for others' safety, that the assaulters, they should be investigated about the event, right?
Yeah, but if she doesn't want police involvement, we cannot force them, isn't it?
Yeah, actually,
Can
there
we
is
advise if she is less than 18 years, then of course it is
yes.
It has to be done
Exactly. Now,
whether
what
they
you have
want
to
or
say is
not.
that you have to ensure the confidentiality. So generally, they understand that it's not something which is going to harm or going to make them popular or something, right? Yeah. But
But
still,
more than 18, I don't think we need to force them. If they don't want,
yes.
we can't force them to tell the police.
Yeah, less than 18, do that. More than 18, suggest that. Okay,
Yeah.
so that she understands that okay, this is something which is important for her and important for others as well. All right. Okay, so shall we begin?
I'm
Yes,
sorry, last
no,
question. So,
please.
Dr. Sidra, less than 18, we have to inform police must. It is must.
Actually, why is it that, why is it there? Because they don't understand the implication of that, right? And the consent age is not there. My suggestion in that case would be that you simply suggest her that this is not going to break your confidentiality. They're going to keep the confidentiality. However, investigation is essential for your safety and for safety of other girls as well. You speak it up, your job is done. She would understand, okay, doctor. So just make those lines so that you are in a safe position in exam, that what you're doing is for the patient safety and not to make her, some sort of target for some discussion or some popularity reason, right? So she has this fear that I don't want to be discussed. You ensure her that we are going to keep your confidentiality. But investigation is important for your and for other girls' safety as well. So this would be a safe line in exam. Okay.
And also, Dr. Sidra, if she has said that she's already informed the police, do we still need to ask how did they look like and all that, because that the police would have done her work.
If she says that they have informed police, so now they can also ask her as well, because this is for investigation and not for the management, right?
Okay,
so
the
police would be
ethnic,
asking them.
like black or white, what did they look like?
If she says that they have informed that in the history earlier, then you skip these questions. But of course, if it comes a little late in the history, then you can ask about how did they look like and all, because you don't know that. So in the beginning, you can say, did you inform anybody? And she says that police has been informed earlier. Then you can skip these questions.
Okay, yeah.
Okay, right. All right. So let's go to the station number 3. And is my friend? Where is my notebook? Harshiba.
Yes.
Hi, Harshiba. Hello.
Hi, ma'am. How are you?
I'm fine. Thank you very much for the escape. Otherwise, I would have missed one station today if
No
Salma
problem.
was not there. Thank you very much,
My
dear.
pleasure.
Oh, great. So let's do the station and let's try to make it easy. Good luck, my dear. Be yourself, huh?
Yeah. Okay, ma'am.
Sure.
Can I start?
Sure.
Hi, this is Dr. Harshaba. I'm one of the doctors in the gynae clinic today. May I confirm your name and age, please?
Yes, hi, Doctor. I'm Kate Gray. I'm 26 years.
Is it okay if I call you Kate?
Yeah.
Okay, Kate, I gather from your notes here that you are experiencing some problems with intercourse. Am I right?
Yeah, exactly, Doctor. I am not able to do the deep intercourse at all.
I understand. I'm sorry. It must be very distressing for you. I would discuss all your complaints and I will address all your concerns, and we will come to a safe and mutually agreed management plan for you. Before I proceed further, are there any concerns that you have to share?
Yeah, that's a big problem which I'm having, Doctor. My partner thinks that it's all in my head. It's nothing out there. He have been seeing there. I saw that in mirror as well. There's nothing physical out there, but at the same time, I cannot do the intercourse. I think of it, I start having pain. And never in my life I had a deep intercourse. And now I'm so fearful of that. It's affecting my relation. And he thinks that I'm doing it on purpose. I swear, it's there. It's not in my head.
Yes, I understand. I understand, Kate. I completely understand, but to know you better, is it okay before we proceed, can I ask you a few questions?
Yeah, please, yeah.
Okay, Kate, I may also need to examine you with your consent in the presence of a chaperone, if that's okay.
Yeah, that's okay, yeah.
Okay. So, Kate, can you tell me more about this problem? Since when are you having it? Hello?
Sorry, yeah.
Yes, Kate, can you tell me more about this problem? Since when are you experiencing this?
Doctor, actually, I started my sexual activity a little late. It was around 24 years, so it's been 2 years actually. And with my partner, I love him a lot. It's not that there's some issue regarding our relationship, but sex is very painful. The moment it starts, I have severe pain, and I'm not able to do deep sex at all.
I understand. So this pain that you're mentioning is it happens when the penetration, is it just at the entrance of your vagina, or is it deep inside? Is it like a burning pain?
Starting from the entrance, Doctor, starting from the entrance, I'm not able to do deep at all. I mean, up till now, my life, I've never been doing a deep intercourse at all.
Okay, I understand. Kate, is it associated with any sort of discharge down there or burning while peeing?
No discharge, no burning, nothing like that. I feel like there's some sort of a block, Doctor. I mean, there's some sort of barrier.
Okay. Do you have problems inserting tampons also, or getting smears done, Kate?
I've not had the smears yet. I did get my invitation. I didn't go for that for this fear, Doctor. And the tampons I've never tried. I always have my sanitary napkins.
Okay. Okay, Kate, you might find my following questions a little bit intrusive, but I need to know because I need to make the best management plan for you. So can you please tell me, has there been any incident where you have been forced against your wishes to have intercourse? Hello? Kate? Can you hear me, Kate?
No, Doctor. Yeah? Yes, Doctor.
Can you tell me a little bit more about your partner, Kate? Has your partner ever received any treatment for sexually transmitted infections?
Very supportive. No, nothing like that.
Okay. Okay, Kate, no problem. Tell me more about your periods, Kate. When was your last period?
Yeah, my period was 2 weeks back.
Okay, are they regular?
Yeah, always.
And you said you haven't gotten your smear done, right?
No, not yet.
Yeah, I understand. Must be very painful. We'll talk about what to do about that. Do you experience any sort of bleeding in between your periods or after having sex?
No.
Okay. Kate, have you ever been in a relationship before your current partner? A sexual relationship?
No, this is the first. No, I started my sexual activity just 2 years back with the same partner, and I'm happy with him otherwise.
Okay. Any pregnancies in the past?
No.
Okay. Any surgeries or operations you've had down below or in your tummy?
No.
Okay, Kate, are you seeing a doctor or a GP for any illness?
No, doctor, I'm fine otherwise.
All right. Any drugs you are taking that you, any allergies you're aware of?
No.
Mm-hmm. Okay. Kate, do you smoke or drink, or I'm sorry to ask, take any recreational drugs?
No, doctor, I do smoke, but that too occasionally. I'm not a regular smoker.
Mm-hmm. Okay. Have you ever thought about quitting it?
I'm not a regular smoker. I mean, just in gatherings, maybe occasionally I take one or two.
On and off. Yeah, no problem. Okay. Do you have anyone else at home? Like, how are things at home otherwise?
Yeah, that's fine. Just this problem that now I'm having in my relationship.
Right, I understand. Okay, Kate. How have you been feeling since the past 6 months? Any episodes of feeling low or tearfulness?
No, otherwise I'm all right, doctor. But now I'm a little fearful that my partner won't be continuing with me if I just, have this sort of problem. I just need a treatment.
Okay. Okay, Kate. Now, if it's okay, I'd like to examine you in front of a chaperone.
Doctor, I'm sorry. I'm not comfortable.
Kate, it's going to be a very gentle examination, and if you feel pain anytime, you can ask me to stop. But of course, it's with your consent. If you don't want me to do it, I won't do it.
Yeah, I'm not happy with that. Can we go otherwise with the management?
I do need to look down there to see whether there's any problem, to rule out any sort of an infection or anything, any scarring.
But you'll not touch me, right?
I will just look down there.
That's okay, right?
Okay, thank you, Kate. Okay, so Kate, I've done your examination now, and I can understand this must be a very embarrassing and awkward thing to talk about. But let me tell you, this is a very real problem, and many women experience such a pain down there during intercourse. So this problem that you have, according to your examination that I've done, seems to be of vaginismus. Have you ever heard of this term before?
No, what is that?
Okay, Kate. So this is a problem basically where your muscles around your vagina, they tend to tighten spontaneously, especially when you're anticipating sex, because there is an association with pain. So they tend to contract to protect your vagina. It's sort of a reflex.
But I don't do that. I mean, myself, doctor, I really want to do sex with the partner. It's not that I'm just doing, yeah.
I understand. I know you are really into your partner and you want to have a sexual relationship with him, but sometimes it's just a psychological trigger, because while expecting intercourse, your mind associates it with pain, and your body is just reacting to pain. You don't need to worry about it. There are management options for it. Okay. There are a lot of women who face this, and I just want you to know that we will be here to support you and help you through this. Is it okay?
That's fine. Tell me the management. I'm ready to do anything to correct that, doctor. Yeah.
Right. So, Kate, first and foremost, I think you should, for a few days, stop attempting intercourse, because all these things will only strengthen the association that you have with intercourse and pain. So you need to stop attempting intercourse for a few days and sit and talk to your partner about it. If you're not comfortable talking to your partner, you can bring him. I can have an appointment with the both of you, and I can explain it to the both of you together. Okay?
Okay, thank you. Yeah.
Yeah. There are other methods as well, where you can, there are certain creams and lubricant jellies that are available that I'm happy to prescribe you. You can use these slowly and slowly. It will reduce friction and will reduce pain. Right. Along with that, Kate, there are psychosexual therapy sessions which you can attend with your partner or without your partner if you want. The therapist can tell you why your body is reacting the way it is and work on you to prevent it from happening. Am I with you?
Yeah.
Okay. yeah, any of the options that you find suitable, you can tell me. I'll tell you more about them to you.
That's fine. Yeah.
Yeah, so the next option again, Kate, is that you can go to a physiotherapist. The physiotherapist will help you perform these exercises that relax your vaginal muscles that could improve intercourse for you. And the last one is we can try training your vagina. There are little instruments from varying sizes, small to large, that you can introduce yourself at your own pace whenever you're comfortable, trying to increase the size gradually. That will kind of train your vagina to anticipate insertion. So, Kate, these are all your options. You can go back home and you can discuss them with your partner. Here are a few information leaflets for you to take back and read, and you can come back to me anytime. I'll be happy to write back to your GP about all these methods.
Okay. Thank you, doctor. Thank you very much.
Thank you.
Okay. How did it go, Harshaba? Very well done. I was thinking that you would be stuck up with information gathering, but very beautiful information gathering, my dear. How did the station go?
Thank you, ma'am. I think I missed asking about any like psychological triggers. I mean, it wasn't very apparent in the history that the patient gave me.
That was about the child abuse, domestic violence, and FGM and STIs.
Yeah,
so these are the triggering factors you need to rule out. And but this shows that the practice is going well. Very good, Divya. Your group, I can see Bindu, Dipti, and Pallavi, all of you are very active and you participate in a beautiful manner. And those first few days, things were a little difficult in the coordination, but now you people are going really good. Harshaba, well done, my dear. Very beautiful. And the best thing was, guys, that Harshaba volunteered today. So she was not prepared for the last 1 week that she's going to present. That means what? That she was preparing each and every station and she was ready for that. This is...
Yeah, actually, ma'am, I prepared this station. I mean, it was my station to prepare in the group. So
very well done. Very well done. Though I would like to improve a management plan, like the organized one in a structured manner. I would like to do that. But still, I would pass you in the information gathering. I would pass you in the communication with the patient. In applied clinical knowledge and patient safety, I'll give you borderline. These two domains, I'll tell you why, because I wanted it to be a little more organized. But otherwise, to begin with, this was a passing station because no big mess up was not done. I mean, no big mistake was done. So that was very good, Harshaba. If it was your station in the mini group, I'm sure if you're going to prepare all these stations like this, you're going to pass this exam, Harshaba. Okay, so that's a wonderful start. I want next station to be even better than this. The graph should be escalating. Okay, and above that, expect me to give a harder station, even harder than this in future. The best thing she did was handling me for examination. Did you all note that? Did you all note that? That she did not force me for the examination at all. And when Harshaba was trying to tell me about the examination, that, you know, I'm just going to have a look, that's it. So that was very comfortable for me. I was not getting annoyed by her. That, you know, that she would like to touch or force me. This was a mistake in which many of the students, they failed in exam because they could not go beyond examination. And they kept on insisting for the examinations, and the role player was not ready for that and they didn't move forward. So that is very, very important. Move forward. If she's not ready for it today, so it's not something like she's going to have cancer if you don't do examination. So just leave her. Tell her that it's okay. In the coming sittings, we're going to discuss about that until and unless you are ready with that. So I'm going to give you lines if she keeps on insisting. I don't want that, because the talk article says that you should not insist if the patient is not ready for that. Please communicate to her, counsel her in multiple sittings. So that is very important to do. Very well done. Introduction, agenda making, that was fine. Harshaba, I would make a suggestion, please. Shift your concern part, which you did after agenda, that wastes your time, okay? Shift that part before management. You got my point, Harshaba? Introduction, agenda is fine, my dear. Then you asked me that, do you have any concerns today? You have to ask that. Take your information gathering, and before coming to the management, say, now before coming to the management plan, so may I know some special concerns you have from the consultation? Why? Because when you ask it there, you can handle that concern there and then, because you're coming to the management plan.
When you ask concerns before information gathering, you forget that while coming to the management plan, what were the concerns. Moreover, it takes your 1.5 minute precious from the information gathering. Am I clear, Harshaba?
Yes,
Okay.
ma'am.
So in the outline, sweetheart, just shift it below down. Ask the same question which you asked me, but asked me before coming to the management plan. Right? So after information gathering. All right. So information gathering, the best part was that you asked about being more painful, the discharge. I told you about the block. Smear tampoons was a very good question, which students they generally forget, because that is one thing which gives you an idea that yes, it's a vaginismus. Very good signposting about sexually forced fullness. That was very good. Also ask about the domestic violence. You can ask about the cutting down below. FGM was ruled out. Any bad experience as a child? Add this one question, Harshaba. So did you have, sorry, pardon me to ask, did you have any bad experience as a child? I would like to know about any child abuse. So this is an appropriate way to ask this question, okay? Now, after this, you asked about the gynecological history, the periods, intermenstrual, postcoital, obstetrics, surgical. In surgical, you ruled out FGM by down below, asking about the down below. Medical history, drug smoking, that was fine. Whenever a patient says that she's an occasional smoker, don't connect her to NHS, okay? Because then you can leave that part. Examination, a very wonderful handling of the patient in examination, Harshaba. Very well done. However, I would just like to tell you that at times patient is like very loud at this. No, doctor, not at all. So you simply say that if you're not ready to get examined, Kate, she was, right? If you're not ready to get examined, Kate, slowly and gradually, prepare yourself to get examined. Slowly, we will be touching that bridge when you'll feel comfortable. And if you allow, I can just see you from outside today and you can apart your lips from your own hands. Would that be okay? Right? So she is comfortable in touching with her own hands. That would give you a clue for any rash, any blisters, any ulcers, or any sort of local cause for the examination. Done? So these lines, you can cram it up if the patient is not ready to get examined. Okay? Now, gentle and the look was the minimal thing she did. That was all right. Now, coming to the explanation of vaginismus, that was wonderful. Yes, sure, Bindu. You can simply say, Kate, she is right. Kate, if you're not ready to get examined, slowly and gradually prepare yourself to get examined. In multiple sittings, we'll do that and touch the bridge. When you feel comfortable and you can allow me to examine for today, if you're all right with that, can I just have a look from outside? And you can apart your lips with your own hands, if that's okay with you. Right, Bindu? So she can just make apart her labia herself rather than you touching because she's not comfortable. Okay? Right. Now, after this, what you have to remember is that you come to the explanation of vaginismus. That was wonderfully done. I was very happy that the vagina suddenly tightens up. Just you try to insert something, and it's an automatic reaction to fear of something for the vaginal penetration. And you don't have a control over that, Kate. I truly understand. However, it is very painful and distressing. But I would like to tell you that it can be treated. It is treatable. Now came the problem in the management plan. You started with the creams. Could that be a little better? How do we do the management plan in an organized way, Harshaba? The conservative one? Yeah?
MDT.
Then the medical, and if at all surgical. This is how we generally divide the management, right? Okay, so I'll give you the management plan, creams, physiotherapists, then you came to the dilators. These three were mentioned. I would like to make it sequential management plan in an organized manner so that you speak one after the other in a structured manner, right? And when you said that avoid sex in the next few weeks or something, I would add on one thing, that please keep enjoying the intimacy with your partner to avoid having a distant relationship. That's very important. So it doesn't mean that you be at a distance if you're not doing sex, right? So you can enjoy the intimacy until unless we begin with the therapies. Just add on those lines because they're important for you as well while leaving that patient. She's going back from the consultation. I would pass you in communication with the patients and the relatives 2 by 2. Everything was fine. One thing which I would like to tell you is somebody has done this station from strategy. Anyone out of you has seen this station from strategy? No? I can share that where strategy says that please draw a picture for this patient. No? Anyone has done this station from strategy, please? Which says that please draw a picture.
The communication between the doctor and the patient, that one?
Yeah. In which they clearly write that visual aid is very important. Okay. So in vaginismus, the idea is basically the brain is not reading. Okay, Rahma, I will post that. Okay, I'm writing down for myself. I'm going to post that document so that you can see that they say that you always have to, it's always better when you're treating with a vaginismus patient, use this visual aid for better understanding. You can say simply that this is the vagina and this is attached to the neck of the womb and the womb here. It is so roomy, Kate, that it can accommodate a baby, and the male organ that is basically, this canal is elastic and can stretch, can accommodate any size of the male organ. This is just to tell you that basically it is a doable thing. So it is to tell her about the structure, that even a big baby can be accommodated, that vagina is so roomy. All right. So this management plan, you can start off with just drawing a diagram as per the strategy instructions for this vaginismus case. Okay. History of presenting illness since when? Is it superficial or deep? One question you can add in just to rule out the relationship with a partner. As I was saying it again and again, so Harshiba did not do that, but you should remember, do you find sex enjoyable otherwise, or do you enjoy the foreplay? That tells you that how much she is into the relationship, right? Any history of PID, rash, intermenstrual, postcoital, she did ask. Child abuse, domestic violence, FGM, she did ask. That was very important. Gynae history about the menstrual cycle and contraception, if at all she's using. Examination, do not force, please. And just speak up those lines which I've made you learn today, okay? MDT was missing. Yes, Harshiba? And for that, patient safety goes borderline, okay? MDT should not be missed. The gynecologist, the physiotherapist, psychologist, the sex therapist, they all will take care of you in this condition. Got it? Yeah? Assessing main concerns was there. Confidentiality in the beginning, sensitive approach was there. And it was a safe plan. However, patient safety and applied clinical knowledge could have been better. It was a primary vaginismus. I've just shown this slide from the talk article to all of you because it can be a secondary vaginismus as well. So if it's a secondary vaginismus, there can be some sort of traumatic childbirth in the situation. So please take care of that situation. Then you're going to deal with that counseling in that, right? Let's see how we have to do applied clinical knowledge for this patient. Whenever management starts, I want you all to be organized and see the first part, information gathering. That's why I tell you in a sequence. Now, when comes a management plan, please don't jump to the surgical options for some condition first or the medical option for some condition first. Always go in a sequential manner. So now coming to the management gate, we have got some conservative options, and we have in conservative options some psychosexual therapy, which is a talking therapy that aims to help you understand and change your feelings about your body and sex. We have the relaxation techniques, which are the mindfulness breathing and gentle touching exercises to help you learn to relax your vaginal muscles. We have the pelvic floor exercises, which are squeezing and releasing exercises to gain the control of the vaginal muscles. And we have some trainers. These are smooth tampon-shaped objects in different sizes. They help you to gradually get used to having something inserted into your vagina. Am I clear about the conservative options, Kate? Now, these go side by side. If the pain is more, we can start with the conservative management. Along with that, we can start the medical option as well, in which we have numbing gel. We have some medicines to relax the muscle and some medicines to decrease the anxiety as well. As in your case, we do not find any local reason, therefore we don't have any role for the surgery. Am I clear about the management options, Kate? Harshiba, wasn't it a little more organized, my dear?
Yeah.
Yeah. So see, I expect from all of you to go in a sequential manner in management so that it seems that yes, you are basically better than others. We have to stand out. It's a competitive exam. I'm going to give my 100% to make you organized, but in return, I want your practice. That yes, you do it in an organized manner, one after the other, so that it's a structured way, and in the role player, in the examiner scorecard, it goes like tick, 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 tick. Now, in this case, there's no role of surgery, but in special WhatsApp tasks, I would be giving a station of a postpartum dyspareunia. Their refashioning would come, because postpartum dyspareunia, if there's some granulation tissue and some scarring, so you should remember here there's no role of surgery, but conservative and medical, just go stepwise in a sequence so that you know. And how would it come to you? It would come to you when you would practice that. It would come to you that one after the other, you know that what I have to speak next, right? Ya Rahma, Bindu, see, this is a competitive exam and we have to be better than others and we have to pass. I always say that in your circuit, if one person has to pass, it should be you. So our preparation has to be of the level that even if a single student has to pass, you should outshine others. And that is the reason I'm against all of you doing in the open forum repeat stations. Why? Because you're telling them you're being trained and they are getting from you, right? So learn from everyone, listen to everyone and catch their good points and understand that they're doing the mistakes in their presentation so that we be organized and we tend to pass this exam, right? Are you all clear about the management options and the applied clinical knowledge, all of you? Done? Are you done with applied clinical knowledge in a sequential manner? How you're going to do that? Only Bindu is clear? Only Pallavi is clear?
Yes.
Okay, Dr. Savia is here as well. Perfect. So please do an introduction, make an agenda. Very good, Jyoti. Information gathering, explain the diagnosis and the cause beautifully as Harshipa did. Management plan we have to improve. Right, Fawzia? Management plan, try to make your bullet points one after the other and make sections like conservative, medical, surgical. So one after the other, you have your things to speak rather than jumping to creams first or the surgery first. Go in a sequential manner. It should be a mutually agreed plan. And wonderful thing which Harshiba said somewhere in between, that I would like to see you as a couple. That was wonderful. I would say that in follow-up as well, that I would like you that you continue your intimacy relationship with your partner, and I would like to see you both in the next setting, if that's okay with you. So this in vaginismus, it's always preferred that both are there so that you can address the concerns and you can cancel them together. Another thing which I would like to tell all of you is that, see, it is not something which is going to be like a miraculous treatment. So in the management, I would like to say that, Kate, I would just like to tell you that we'll start with this treatment. Under the expert care and the specialist guidance, it is treatable. However, we see the progress in a matter of weeks rather than days. So you keep on practicing these exercises at home. And along with that, you can come with your partner for the further counseling as well. So my point is that she should not think that today I've started this and tomorrow I would be okay. So it's basically, it takes certain weeks. So I will say this one line to her, that we do see the progress, but in a matter of weeks rather than days. So the consistent doing these exercises and starting with this management from today, the things would be better in the coming times, right? So in follow-up, just say this one thing so that she's sure that it's not something that, you know, tomorrow she would be having no vaginismus at all. All right? Okay. Any questions, my dear, regarding vaginismus? One after the other, we are doing difficult stations today, right? But yeah, let me tell you that these stations are not like 14 stations of exam. These are like one odd station out of 14. All right? So the stations we are doing are like one station out of 14. So don't think that entire exam is like this. Exam has like 9 to 10 stations, super easy, very straightforward. If you know the things, you can just speak it up and you can just handle the station. But yes, it happens in this difficult station like assault, like vaginismus, that you tend to lose your confidence. I just want that you all be very confident in this station because you have been given an organized information. Just practice it. Yes, Divya, it is. From sexual module, it is generally a difficult station. So we are going to make it easy. You're going to practice it tomorrow. Tomorrow, one day, you're going to revise these stations from the recording. You will finalize your things. And day after tomorrow, we'll go to the early pregnancy. Okay? All right. Thank you very much. Remember, please, signposting is very important whenever you talk about the sexual history. And Harshiba did that. I'm very happy, Harshiba. Just organize your management plan, and I'm sure you're going to pass this exam. I'm going to give you a little more difficult station, and I'm sure this is going to be the one which you have not prepared in your mini group. Okay? All right.
Ma'am, I wanted to ask something. In
Yes,
this case, there is nothing underlying. There is no underlying cause for her vaginismus.
Mm-hmm.
Is that possible? I mean, there always has to be some psychological trigger.
Primary vaginismus can be like, you know, anything which is some sort of fear she has of insertion. So we don't have any cause in some sort of primary. In secondary, we can relate it to something, you know. So there can be without any cause, but counseling does work in this as well.
Okay.
So we just
I thought I was missing something in history.
No. Everything was all right. You did mention everything to rule out, my dear. Okay. All right.
Can we ask in this vaginismus module, can we ask the patient about her views about sex?
Yeah, you can say that. How do you feel about sex? As I said in the HOPI, do you find pleasure in sex? Or may I know your views about sex?
Your views about sex. Like, does she feel ashamed of, you know, having sex?
Yeah. That's a very valid question. You can formulate it. May I know your views about sex? So that's why, you know, somewhere in Harshipa's talk, I was also thinking that I'm very happy about that. I want to do that, but it's not something in my control. So that shows that, okay, she's okay with this. Otherwise, there can be like few people who have their reservations or who are a little having a little shyness, or they're shameful for this act. So you can just pick it up, and they just require counseling for this. Okay, because no physical flaw is there, no physical defect is there. It's simple that we just need to train by insertion that it can be okay. So they just need counseling, and the sex therapist talk to them, psychosexual therapy. All right.
All right.
Okay. Thank you very much for a wonderful going. So let's go to the station number 4. And if I'm not wrong, we've got Dev, or Girija. Wait. 1, 2, 3, 4. We've got Girija. Hi, Girija.
Hi.
How are you?
I'm good. Feeling anxious for the station.
I can understand. This is natural. So what is the pulse rate at the moment, the heart rate?
Must be 110.
Oh, really? Okay. So wonderful Skype meetings you people are having, huh?
Yeah.
And to get good score, Ramya daily places one screenshot so that, you know, ma'am is noting down, and please don't cut down the score from the group. Huh, Ramya? Okay, right. That's wonderful. Keep on going in this manner. So Fawzia and Khanda able to join?
Yeah, Khanda joined once. She's busy with her postings. Fawzia joined.
Okay, right.
But we've recorded the sessions for Khanda.
Yeah, that's wonderful, because, you know, Khanda is having this 1 week a little difficulty because of shifting from one place to other, I think, in hospital. So she'll be okay after 1 week, right? Okay, so let's begin the 2 minutes and start now.
Okay, next slide.
Sure.
Can you please move to the first slide?
Sure.
Okay.
Start, please.
Hello, I'm Dr. Girija, one of the doctors in the A&E today. May I confirm your name and age, please?
Yeah, hi, doctor. Doctor, I'm Parul Joan. I'm 23 years. Doctor, I'm having pain in the blisters.
I'm so sorry to hear that, Parul. Can I offer you some pain relief? Has anyone given you something?
No, nothing's been given. I would be grateful.
Yeah, sure. I would ask my midwife to give you some pain relief medications right away.
Okay, thank you.
So how are you feeling, Parul? Is it okay to continue?
Yes, I'm better. Thank you, doctor.
Okay. Parul, today you're here because you have these painful blisters since yesterday, right?
Yeah, exactly.
So we would discuss about it, and I would discuss the best possible management plan for you. Before we move on to that, is it okay if I ask you a few questions to know more about you?
That's okay.
Can you describe these blisters for me, Parul?
These are very painful. These are very small. I just had a look through mirror, and they're burning as well.
Okay. And is it yesterday was the first time it started?
I saw them for the first time yesterday because I was having pain down below.
Okay. And do you have any fever?
No, I feel that I'm having a little. I'm a little warm. I don't know on thermometer if it's there or not.
Okay. And do you have any discharge from down below?
No, doctor.
Any problems with your waterworks?
No, doctor.
Okay. And have you had any other blisters anywhere else in your body?
I didn't notice that.
Okay. But the pain is only down below, right?
Yeah, it's burning. It's painful.
Okay. And has anybody else in your family had this now? Yeah, especially your partner?
I'm not sure. No.
Okay.
Did I get it from my partner?
Yeah, we'll just talk about it. I'll just come to that in a bit.
Okay.
And any other problems you have currently?
Other problems as in?
Any other symptoms that you would like to tell me?
No, I'm fine otherwise.
Okay. And I understand from your notes that you're 6 weeks pregnant.
Yes, doctor.
Have you booked for the pregnancy?
Yeah.
Okay. So can you describe to me, have you had any booking blood tests?
Yeah. All the things that were done, and ultrasound was also done. They saw the heartbeat of the baby, and the pregnancy is going fine. I don't have any problem with the pregnancy.
Okay, that's good.
My first pregnancy, doctor.
Okay. And have you had any other miscarriages or anything like that before?
No, this is the first time I've ever been pregnant.
Okay. And what about your menses, Parul? How are they?
I had it 6 weeks back, yeah.
Okay. And are they regular?
Always, yeah.
Okay. And do you have any medical conditions?
No, I'm fine.
And have you had any operations in the past in your tummy or down below?
No.
Okay. And do you know your blood group, Parul?
Yeah, that's O positive, doctor.
Okay. And any illnesses that run in your family?
No.
Okay. And sorry to ask you a few personal questions, Parul, but they are important for me to decide a management plan for you. Can I proceed?
Okay.
Okay, so can you tell me more about your partner, Parul?
What do you want to know about him? He's fine. He's healthy.
Okay, since when are you in a relationship?
With him, maybe 1 year. He's father of my baby as well.
Okay. And have you or your partner have any sexually shared infections in the past?
I'm not aware of.
Okay. And any problems with sex, Parul? Sorry to ask you these questions.
No, I don't have any problem with the sex now. Of course, it's painful because of these blisters. Since yesterday we have not met.
Have you noticed any blood after bleeding after sex?
No.
Okay. And pardon me to ask, do you smoke?
Smoking, not doing in pregnancy, doctor.
Okay, that's a good decision, Parul. Do you take alcohol?
No, not in pregnancy.
And pardon me to ask again, do you take any recreational drugs?
No, I am not taking any.
Okay, okay. And how have you been feeling in the past 6 months, Parul?
Yeah, I'm all right. I'm very happy with the pregnancy and everything, doctor.
And how is the support at home? Who do you live with?
That's wonderful. My partner is really supportive.
That's good. And what do you do for a living?
Yeah, I'm a teacher.
Okay, okay. Thank you for giving me all that information, Parul. So I do have your investigation reports as well. You had a test for the blisters, and I also have your examination findings. So I can see that there are some water-filled blisters down below. Okay. And also the report shows that you have something called, it is a viral infection, which we call as the herpes simplex, the genital herpes, okay? Have you ever heard about this?
No. How did I get that?
So usually, Parul, this genital herpes is transmitted by any type of sexual contact, and the herpes as such can be seen in mouth as well as the genitals, and it is usually transmitted by any sort of sexual activity. Okay.
You mean the current partner?
Yeah, it is possible that you could have got, because that is the only way that you can usually get these infections.
Oh my God! But from where did he get then?
The thing is that sometimes these infections, we can have them due to lack of immunity as well. And it is quite a common infection to get, Parul. And many women in their reproductive age group might have this infection at some point of time. And we cannot exactly say from where you could have got it.
Okay, so do we have any treatment for that? I mean, I'm worried
Yes.
about my baby.
Yes, definitely. I was just coming to that. So this herpes simplex infections usually, since you are very early in your pregnancy, you're just into the 6th week. So we have treatment available for it. And you would be cared by a team of experts, okay? And I would also involve my consultant, and we have a team of experts called the MDT, where we would also involve the gum physicians who are specialists in these sort of diseases, viral infections. And I would also have them to have a look at you, and we would start you on a special antiviral drug, Parul, called acyclovir. Am I clear so far?
Okay, so that's not going to affect my baby, right?
Yeah, so this acyclovir drug, Parul, this is not licensed for pregnancy, but it is seen that it is quite safe for pregnant women, and there have not been any problems with the babies in women who have been given this drug, okay? And it is a very effective drug which you can take. You need to take it 3 times a day for about 5 days right now.
Okay.
And usually,
in what dose, doctor?
Yeah, it is 400 milligrams, Parul, which is to be taken 3 times a day for 5 days.
Okay, that's it.
And then, since this is the first time you got this infection, the risk of the baby getting the infection is around if 100 women have this infection, around 41 of them would have the infection transmitted to the baby. Okay, evidence says that.
Okay.
So that is why, to prevent the transmission to the baby, we would also need you to take this drug again near delivery. So we would start you to take it from 36 weeks of your pregnancy, and you would need to continue it till delivery. Okay.
That's gonna be cesarean section?
No, Parul. We can offer you vaginal delivery as well. So this whole pregnancy, we would be doing all the scans as routine for you. The screening, blood test, and the scan at 11 weeks, and the anomaly scan at 18-20 weeks. And then we would do the growth scans as well. And at 36 weeks, we can decide about the mode of delivery. I would also put you in touch with the pain doctor at that time for pain relief. And we can offer you both modes of delivery, vaginal delivery and cesarean section. Since you have got the infection now in the first trimester, we can offer you vaginal delivery as also. Okay.
Okay.
If you had got this infection later in pregnancy, then we would have recommended cesarean section only, because that would be the safest mode of option available. But right now, we can discuss both options, and I would also discuss this with my consultant as well. Okay.
Okay, I get that, Dr. Rai.
Is there anything else you want me to address right now?
Yeah, like right now I can go back home, or I need to get admitted?
Parul, it depends on the pain. If you feel comfortable, then I can give you the pain relief medications and also a gel to put there, a numbing gel. And you can start these tablets and see. If in case you wish to get admitted, then I can offer you that as well.
Okay, thank you very much, doctor. I think I'll take the medicines. I'll go back home.
Okay.
Thank you very
So
much.
I will also give you a patient information leaflet about this condition, which you can give a read to.
Yes,
okay.
I will read that, doctor. Thank you very much.
Thank
How
you.
was it, Girija? Wonderful. A comparatively an easier station, no?
Yeah, but actually this section health module, I was all into the non-pregnant stations for practice, and then I have this pregnant patient in front of me today.
So did I be kind to you of giving a relative easier station as compared to vaginismus, emergency contraception?
Yeah, I guess so, but I don't know how I did it.
No, you did wonderfully. That was a good station. Very well done. Yes, friends, how did Girija do? Yes, Rama, Jyoti, how was the leader? Fawzia, how did the group leader do the station? Okay, so what things you could have done in a better manner? Tell me, because yeah, appreciation is lots of things are there. So tell me those things which you could do in a better manner.
I don't know. I was not sure of the vaginal delivery actually. I was confused.
Okay, and
that was fine.
That can be done. You're right. After 28 weeks, we go for cesarean section primary. I've made algorithms for you. I'll just show you in a bit. Okay. Other than that,
and history, I had to think of points to collect. I think I could have been much more organized.
There was a little delay in a little fumbling in. I've written where after shifting from gynae to before HOPI, you were taking pauses in HOPI that okay, maybe I'm missing out at something.
Yeah. Actually, it's been a long time practicing antenatal stations.
Okay, I understand. And one more thing, I know this is a different template, but I'll tell you guys in antenatal care after early pregnancy and in maternal medicine as well. Whenever such station comes in exam, there's an overlapping in this station, right? So remember the effects on the mother and the baby. They should be part of the station.
Oh yeah, right. I completely forgot to tell her about neonatal herpes and
so what it means to her and what it means for the baby. Just touch it for like 15-20 seconds. We'll practice that in antenatal care and maternal medicine. I'll give you the template there that how you have to touch that. But whenever the pregnancy is there, then that part should be touched for at least 20-30 seconds, right? Yes, vaginal delivery can be done, Ramya. Yes, it can be done. Okay. So introduction was all right. You're talking to the patient rather than saying that, do you want me to offer? If she's saying pain, you say that, yes, I've called my nurse rather than midwife. I've called my nurse to give you the painkiller. And she is, after that, take a pause. One, patient safety, you all have to remember. All of you, there would be stations coming with emergency situation that you have to give some painkiller.
Allergies.
Yes, thank you very much, Girija. Always speak a line that my nurse will be coming just to give you a painkiller. Before that, can I just ask you that do you have any known allergies? Okay, just make it a fixed line. Whenever in emergency you're giving out something, rule out the allergies at the top. You have to do that because it's your patient safety. Point noted, everyone, because now in future, when emergency questions would be coming and you have to deal with that, I would ensure that you people memorize this thing and you people practice this thing. Okay? Only Bindu has understood that. Where are you guys? Be active in the chat box. Are you people? I can see somebody like doing multitasking with kids and kitchen and television. Paying attention here. Be active in the chat box so I can see. Thank you very much. So you all are awake. Thank you very much, Dr. Sujata. Great. Okay, so Dr. Sabia is awake as well. Yeah, Divya. No, you're coming next. So no chances of getting asleep, huh? Well done, Harshiba. Thank you. So please remember these points. I would be noting down because the thing which I've said for once, I take it for granted that you're going to practice in that manner, right? So this one line you all need to remember. Very good. Yes, Divya, all would be okay. Then you came to the asking about the pain relief, the fever, the discharge, the blisters, about the partner history, the pregnancy, the last menstrual period, medical, surgical. You asked about the blood group. That was very good, Girija, because she was pregnant. And personal question, you asked about the STIs, the bleeding after, smoking, alcohol, recreation, drugs. In history, Girija, in history, I have noted down that when there was a little fumbling in the question of about the sexual partners. See, it is a disease which comes with we know that it's because of the sexual contact. Why not to be confident? And I told you categorically with this partner, did you hear to my words in response to your question that with this partner, it's been 1 year and he's father of my baby.
So
my second question would my
second
question would have been that few of my questions, as if you had done the signposting earlier, might sound a little intrusive and personal to you. May I know that are you having multiple sexual partners? This would be my straightaway question, rather than how is your relationship with the current partner? This gives you no clue regarding herpes. Now, my answer would have been, yes, doctor, I had multiple partners, but it's been around 6 months that I'm just with this partner. I have other partners as well. Now, if you say that this is a sexually transmitted disease, and I say, from where did I get that? Your answer was absolutely right. Be very diplomatic and don't name or blame the current partner or the previous partners. You say, Parul, I respect your concern. However, at this point in time, it's very difficult for me to point out as to from where you got this infection. However, we are going to refer you to the specialized clinic. We call it as gum clinic. And if you allow, the contact tracing can be done and they can find out and treat other partners who are affected as well. Would that be okay with you? So this is a patient safety. Contact tracing was not done. Yeah?
Yeah.
So only for this reason that contact tracing was not done, that it is, you have to be around 1 or 1.5. If I'll be like easy with you or relaxed with the marking, it would be like 1.5 in patient safety. Otherwise, it would go borderline. Because contact tracing, if you're not doing that, you are continuing with that vicious circle of having an STD. You get my point? It's a very important point in an STD. Always do the contact tracing and seek her permission if she's all right with that. If she says no, even then you can do contact tracing, not telling that this is the partner, because generally they have multiple partners or more than one. So it's not that they would come to know about that. About your management plan, I was very happy. Yes, acyclovir is there. You did tell about not being licensed. That was very good. You did tell about the 41 out of 100, Girija. That's a perfect way. Did you all notice she didn't say 41%? 41 out of 100 women. This is an ideal way to talk to the patient in a patient's language. Communication with the patient, I've given you 2 by 2. Greeting, introduction, self-role, checking the patient's name and age, settling pain of the patient in the beginning, but rule out allergy. Because of not ruling out allergy and not doing the contact tracing, I've made you borderline in patient safety, Girija. Now, history of the lesion. It was the first time. Have you ever suffered from cold sore in the mouth? Can you score the pain from 0 to 10 to me? Whenever pain is there, this is my way of pain scoring. I used to do that in all types of pain. May that be bladder pain syndrome, may that be some sort of pregnancy with abdominal pain or something. I always used to ask my patients that, Can you score the pain from 0 to 10 to me to know the intensity, right? Here you have given the painkiller, it's fine. It's just to give you the clue that how do you ask to the patient from the pain score, okay? Any burning sensation, difficulty with pee? You asked about the vaginal discharge, fever, that was all right. May I know about this first pregnancy? Asking about the folic acid is important. She's at 6 weeks, Garija. I know we have not revised the template. Therefore, you have not remembered that. But for future, remember, whenever it's an early pregnancy, ask about the folic acid. Now, sexual history, directly ask about after the signposting, directly ask about the multiple partners. It's very, very important. Okay? Gynae, obstetric, medical, family, surgical, drugs, personal, social, mental health was done. You will all find in this. So information gathering goes 2 by 2. Patient safety. Gum clinic was missing. Multidisciplinary team was missing. Why, Girija? Tell me what would be the multidisciplinary senior consultant. Yeah?
I mentioned consultant and gum. I couldn't think of anything else.
You did mention gum. Yes, you did mention gum.
I told MDT as well.
Yes. Okay, fine. Yeah. So remember, ruling out STDs, other as well, is part of this sending stuff. Why? Because one is done, then we check for other STDs as well as per the
we need to take swabs for
exactly. We need to take swabs for the beginning. Why? Because one STD is there, you need to rule out others as well. So it is not licensed. You did mention that. So these 1 or 2 points, contact tracing, allergy, and ruling out STDs makes patient safety goes borderline. Apply clinical knowledge, let's make it simple. Now, yes, IgM is positive, Ramya. It's a recent infection. That's the first infection. Okay, Dr. Sabia, we are all coming to your place for the food, huh? Okay, so primary herpes, remember, if it comes as a primary herpes, now what I'm going to do is, I want your attention, everyone. Give me a thumbs up in the chat box so everybody is awake, because we are going to do herpes in all types of situations whensoever it comes in exam, okay? So what we are going to do, Midhat, is that primary herpes, if it comes in exam, Midhat, we'll take the viral swab. Why am I giving Midhat importance? Because he's the only guy. And among all the ladies, I don't want he to feel that, you know, he's not being given importance. Yeah, Midhat? So we are respecting you, Midhat. Okay, so taking viral swabs, for HSV PCR in taking type-specific serology is the first step if it's not given in the question, right? If it's not given in the question, you have to send it in your management plan. If it's given in the question, you say it correctly and you interpret that, okay? If IgM is positive, that means it's a primary herpes. Now see the gestation, please. In exam, if the gestation is less than 28 weeks, you will start acyclovir 400 milligram TDS for 5 days, refer the patient to gum clinic, which should not be missed, and then prophylaxis from 36 weeks till delivery. This is what Girija did because it was in the 6 weeks. Now, this has to be a vaginal birth. If in exam, the gestation is more than 28 weeks, what you're going to select is acyclovir 400 milligram 3 times a day, and you will tell her that you'll start it today and you'll continue till your delivery. And it is going to be a lower segment cesarean section. Am I clear about all the types of cases which will come in exam regarding the primary herpes? Clear?
Yes, clear.
Very good, well done. Now, if the question comes that the patient has had the viral swabs or she gives the history of having it earlier and you have IgG positive, that means it's a recurrent herpes. Now, any gestation for recurrent herpes, you will not give the treatment at that point. You will just give the supportive treatment at that point, that is the numbing cream. You'll give the antipyretics at that time if the patient is running fever, and you can also tell her about the warm salt water washing. Yeah, Girija, we can also offer her this management, okay? The saline wash. Prophylaxis from 36 weeks would be started, and again, it is going to be till delivery, and it's going to be a vaginal birth. Am I clear? If recurrent herpes, how you're going to treat that? And if it's a primary herpes, how you're going to treat that? Right? Any station can come to you, so you should be knowing that how would you be managing the primary or the recurrent herpes in exam. For this station, just remember that whenever you do the introduction, agenda, information gathering, explain the diagnosis, the management plan, address the concerns and mutually agreed plan it should be, and then follow up. For this patient, in the management plan, tell her about the effects on the baby and the mother, because this is an overlapping of the maternal medicine and antenatal care template here. Otherwise, the management went well. Apply clinical knowledge, I will give you 2 by 2 Garager. Communication with the patient 2 by 2. Information gathering 2 by 2. Patient safety, just I'll give you borderline for those 2-3 points which were missing. Okay, right? So it was a wonderfully done station, very well prepared. Be prepared for a difficult station next time. Right?
I want to ask one thing, Dr. Sidra.
Sure,
This
sir.
41% transfer is when the patient is having primary herpes after 28 weeks.
Yes, after 28 weeks.
So in this case,
if we do the vaginal delivery. So that's why we don't do that.
This patient only 6 weeks now and she got primary herpes.
So you can yes, this percentage you can avoid saying here. You say that if it is in the advanced case after 28 weeks in the 3rd trimester, then this is basically the percentage, and that too not in cesarean section. That is only for the vaginal birth.
Yeah.
Okay.
Okay. So if it's a cesarean section, then it's not required. All right.
You can say that the risk is high when it is later in pregnancy and when it is vaginal. In your case, it will be much lower.
Lower, yes, because it's way too early and we have got time. And basically, what happens is antibodies, they're formed. Basically, that's why we go for the vaginal birth, right? And that's why.
Dr. Sidra, you asked me, can I go home? So
yeah, that was a fine question.
Okay.
The way you handle it, yeah.
Okay.
If she is having retention, always admit her with the catheterization. I will do one station, I think one module it is there. I'll do that station later with you guys, in which the patient is having with urinary retention and she's here with the herpes. And another important thing is that if she is fine with the settling with the pain, you can give this as an outdoor management. That's not a problem. So you managed that question well, therefore I didn't mention that. Okay. Right, very well done. So great going, huh? Okay, so let's begin with the station number 5. Now we have got Divya, and Divya is like look dub heartbeat. Hi Divya, how are you?
Hello, Dr. Sidra. I'm good.
That's wonderful. So friends, Divya is really good in baking cakes, and she makes master cakes. And if you see her and catch her in her Facebook, you'll understand that she makes beautiful double and triple story cakes, huh? Yeah.
Yeah.
So that's really good. One day we'll celebrate.
With a cake. Yes,
we'll have Yoma COT, we're going to have this cake ceremony, huh? Cake cutting ceremony.
Yes, Dr. Sidra, a special one for you.
Oh, I'm grateful. I'm grateful. Okay, so let's enjoy Divya's presentation and start 2 minutes time. Okay, stokies. Let's begin, friends.
All right.
Go ahead.
Okay.
Sure.
Hello, I'm Dr. Divya Prakash. I'm one of the gynecologists in the clinic today. May I have your name and age, please?
Yeah, hi, doctor. Doctor, I'm Julia Phillips. I'm 29 years.
May I call you Julia?
That's okay.
Hello, Julia. So I assume from your letter that you're here for laparoscopic sterilization. Am I right?
Yeah, I was planning for a keyhole surgery to block the tubes, doctor.
All right, Julia. So, Julia, first I would like to know a little more about you. I might have to ask you a few questions. We'll go through about which will help me to come to a decision about you. And then we'll discuss all your concerns and we'll come up with a mutually agreeable plan if that's okay with you.
That's fine, you know?
Yes, and I might have to ask a few questions that might sound a little intrusive if that's all right.
That's okay.
Okay. Can I know more about you, Julia?
Yeah, the problem is, doctor, that I'm done with my family. I have a condition, epilepsy, and I've been on the treatment. It's been long. I'm taking my carbamazepine. I'm also taking one other drug, sodium valproate. Now, the issue is that I am completing my family, and it had been really trouble with the previous pregnancies as well because of this condition. And I'm happy that I've got a boy and a girl. Now, I simply want to have fear-free sex, that, you know, I not be getting pregnant. So I've just decided for a permanent blockade of the tube. That's it. So this would make me at least easy in my life, that I don't have this fear that I'll be getting pregnant, doctor.
All right, Julia. So you're basically fear of being pregnant. Am I right?
Yeah, yeah.
Yes. All right. So are your periods regular?
Always, yeah.
All right. When was your last period?
Yeah, that was 2 weeks back.
Do you have any pain when your periods come?
No.
No. All right. And are you using any contraception?
At the moment, we practice condoms, but I'm really scared of that.
All right. And when was your last smear? Are you updated with your smears?
Smear, I had one that was all right, normal.
Okay. So, and you have two kids, am I right? A girl and a boy, like you said.
Yeah.
Were the deliveries normal? How was
Both
your
were
first
cesarean
child?
section.
Oh, all right. What was the indication for cesarean?
No, first was bottom down, and second, I didn't go for the labor myself.
Okay, all right. So, were there any complications during the surgery?
Nothing. Everything went very smooth, and I was back home like next day after the cesarean.
All right. So, how long have you been an epileptic? Have you been having fits?
5 years.
All right. And you're on carbamazepine and sodium valproate. Any other medications you're taking for any long-term illness? Anything you go to your GP regularly for?
This is it. Only epilepsy.
All right. Any diseases running in your family that I should be aware of?
Not I'm aware of any.
All right. Any other surgeries other than the two cesareans?
No.
No. All right. Are you on any other drugs, medicines?
No, doctor.
Are you allergic to anything?
I'm not.
All right. Great. So, are you aware of your weight to height ratio, your BMI?
Yeah, that's all right. There's 23.
Oh, that's good. So do you, if you don't mind, do you smoke or drink?
I am an occasional smoker. Yes, I do drink like in parties or gatherings.
All right. That's good. And if I may ask, do you use any recreational drugs?
No.
All right. How do you feel? How have you been for the last 6 months? Have you been feeling low or depressed or anxious
No,
about
we're
it?
a very happy family, doctor. Nothing of that sort. But just like, you know, every cycle when the periods they get a delay of 1 day or more, I mean, I'm so nervous at that time. I want some permanent solution to that.
All right. And can you tell me about your partner? Are you with a stable partner? Are you married?
Yeah, I'm married and I'm very happy with my partner.
All right. So, and have you had any infections down below recently or in the last few years?
No.
Nothing like that. All right. So, Julia, from what I've heard, is there anything else that you want to tell me?
No, that's it. I would just like to know that when I'm going to have this tubal blockade.
Yes. So tubal blockage is basically a permanent surgery that we do where we go in and we block your tubes or cut it based on what. If it's going to be through a keyhole, we're going to go in and block the tubes. It's a permanent procedure. The reversal is going to be very difficult. So even if you want a child later on in the future, we'll have to go through another surgical procedure, which is not funded by the NHS. So you'll have to pay for the procedure. And I feel like at 29, we don't usually do the surgery for women who are less than 30, unless there's an actual indication for it. And
I don't want, I'm very happy with the kids. I don't want any other kids. Why would I want the reversal?
There are a few other options I would like to discuss with you. Is that okay, Julia?
No, my point is that I won't like to have a reversal. So why not to go with this?
Yes, you can actually have the surgery, but usually we find that women who end up having a sterilization procedure before they're 30 at a younger age tend to regret it later on in their lives. You or your husband might decide to have more kids later on, and then it would be too late to go back. But there are other things that we can use that are less cumbersome, that actually have better success rates, that you can use over a period of time, that will give you a prolonged protection as well. And then later on, once a few years have passed by and you're sure that you want to get sterilized, you can always come back and we can always sterilize you. How does that sound? And also you've had 2 cesareans. And so there is a risk that you might injure your bowels when we put in the laparoscope. Because in laparoscopy, what we do is we're going to put a little hole in your belly and then introduce a tiny tube inside. And we might come across some difficulties in the surgery. And there are more risks as well associated with this right now.
Okay, so what is the alternative?
Yes. The alternative is something called a long-acting reversible contraception. So there are, for you, we have 3 methods. One is the which is a copper T. It's a little loop that we can place inside your uterus. And the other one, how are your periods? Do you bleed a lot during your periods? Or is the bleeding?
No.
Good. And the other one is an injectable. You get 1 injection every 3 months and you come back to us after 3 months. And that's it. But the copper T, it's a long-term thing. You can have it in for 10 or 12 years. It's a very simple procedure. You don't have to go under anesthesia. You don't have to go into an operation theater. There's almost no pain involved. And we can just introduce it. You can just walk in, have the copper loop placed, and you can walk out of the clinic. It's as simple as that. And you will be protected over the next 10 to 12 years. Anytime you want to remove it and go in for a permanent method, you can do that as well.
Okay, so these 3 options I have only.
Yes, that's because you are taking a few drugs, like your carbamazepine. What it does is, I cannot give you the pills or the implants like I can give others, because these drugs are known to interact with your medications for your seizures, and efficacy is known to come down. So we cannot go for those less invasive or alternatives. But the best one is going to be copper T. If you don't want to go for that, you can have a shot as well, once in 3 months.
I get that. Okay. So I don't have any other permanent method, like without blocking the tubes?
Yes, you can. There is one other alternative that I can discuss with you too, but that goes, you can also have your husband vasectomized. But I would prefer that you have a little cooling period. You wait for a few more years before you come up with a permanent decision to get sterilized permanently for once and for all. There's also the Eschia method, which is a tiny tube that we place through the neck of your uterus from down below. We place 2 little coils inside your tubes, and in 3 months, your tubes will be completely blocked. But again, that's another permanent procedure. And over time, we've seen that women who go for sterilization, any permanent procedure below 30 years of age tend to end up regret having done that later on. And I really care for you, and I don't want you to regret any decisions you make now, Julia. I understand your fear. I understand that that you really freak out every month when your periods get delayed by a day or 2. But with such good alternatives, I would suggest you go in for the long-acting contraceptives, like the copper T or the injection.
Okay. I'll just discuss with my husband and we'll get back to you on this.
Definitely, Julia. I have a few leaflets and I'll also point you to some links that you can go through. And if you want, I'll also fix up a consultation with my consultant. All right?
Yeah, that's fine.
That's
Okay.
okay with you? So you
Yeah.
can have another person's perspective on this too. How
Sure.
does it sound, Julia?
Yeah, I'm fine. I'll just think about that and get back to you, doctor.
Okay. All right.
So how is the station? Thank you very
Very
much.
short. Thank you very much. Wasn't it very short? What is the time, Dr. Sidra? I'm really
30 seconds, yeah, 20 seconds more. So that was 10 minutes. These 10 minutes, 10 and 2 minutes and 10 and 2 minutes in the entire circuit that flies like, you know, with a blink of an eye. That's a very fast time. So you took around 10 minutes and 15 seconds.
For the first time in a week, I've been on time, but I'm not sure I did well.
No, that was a very good station. Very well done. Again, this was as compared to the first 3 stations we had, that was an easier station as compared to that. But I had to prompt you like on vasectomy. I had to prompt you on like telling me that these things, because I was waiting for these things that they should come on the management, right? Good communication, Divya. Communication with the patient goes 2 by 2. Little jargons were used in the beginning.
Yes.
Introduction was all right. And in introduction, I would just make a suggestion, please. Divya is fine, or Dr. Prakash is fine. I mean, 2 words, it's not, I mean, skip up 1 and use 1 word.
Okay.
Okay. So either make it Divya or make your second name, whatever you're comfortable with. But whenever we speak extra, we are using even our precious like 2-3 seconds. We can use an extra thing like, so Dr. Divya was fine or Dr. Prakash is fine, whatever you're comfortable with, right? Now, agenda, a jargon was used in the very beginning that you're here with the laparoscopic sterilization.
I know.
You can simply say that you're here. I wanted to correct that, so I corrected in return, talking to you that I'm here with the blockade of the tubes. I want it through a keyhole surgery, right? So for that, I would just like in communication with the patient, a little deduction that jargons are not accepted, and that too in the first meeting. So maybe the patient says that, doctor, what are you talking about? So whatever agenda is, that go in the patient's language, okay? The information gathering went very good in the first question. It was an open question. So may I know more about your concern, or may I know more about your condition? That was very good. That made me tell you everything about the epilepsy and about the medicines I've been taking, all my fears, all my concerns, everything.
Okay.
You came to the last periods. You asked about the condoms. You asked about the smear, cesarean section, recovery. You asked about the epilepsy, then medical, family, surgical, allergy, BMI, smoking, alcohol, recreation, drugs. You asked about being a happy family. Yes, I'm happy with my partner. I'm married. Am I in a stable relationship? Then you came to the infection. And then after asking the partner history, some sexually shared infections were asked, and you came to the concern of sterility. Now, information gathering, almost everything was covered up. And one more thing which I would like to tell in the management plan is that you did tell the tubal blockade that how do you do that? It's a permanent method. And along with that, you continued with the complications. It is a type of negotiating station, like the pros and cons of each. I would suggest that you give some positive points regarding the keyhole surgery, the blockade of the tube, and then you come to that I have few concerns regarding that. Can I proceed?
Okay.
So make a break there. Appreciate her choice first. Tell what good points are there. What you did was that in one go, you appreciated the choices and you mixed it with the complications anticipated or some sort of regrets points. And then you said, I have few other alternatives to discuss with you. Can I discuss that with you? What you should do is that do the appreciation regarding the laparoscopic sterilization, then tell that I have few concerns regarding this. So can I proceed? Tell about the regret part which you did. Tell about that it won't be funded, the funding of the reversal of my NHS would not be done. And also,
and also,
let me mute Pallavi. Okay. And then after that, come to the alternatives. And yes, the alternatives were long-acting reversible contraceptive. Here Here, the long-active reversible contraceptive, they are hormone coil, the 3 monthly injections, the copper coil, and also the rod in the arm. We cannot take it out at this moment, but when we'll come to it and telling it's one line, we would say that as you're taking the medicines for epilepsy, therefore it is not a suitable option.
Okay.
You get that?
That's
Telling
how
about the option is your applied clinical knowledge. Pills are not long-acting reversible contraceptive. They're short-acting. So pills I was not expecting, but Implanon, 4 things you have to tell about the long-acting reversible contraception.
Okay.
And then tell yourself about the vasectomy as well. Therefore, it goes in a, yeah, it goes
rate of condoms, which I didn't.
Yeah. So then you have to go in this manner, that this is going to be the applied clinical knowledge, and hysteroscopy Assure had been has not been done because of the patient safety now. So the recent talk article says that now Assure is not being done. So you didn't mention it in the end, but in the last 1 minute, you just mentioned that this is also one procedure.
I didn't know what other procedure you were asking.
I wanted about the vasectomy actually, that's it. Yeah, I wanted to know about the vasectomy actually, that's it. So let's see how the applied clinical knowledge goes. The communication with the patient was 2 by 2, greeting, introduction, that was fine. Just avoid jargons, okay? You have to work on this, that avoid using jargon.
I realized that the moment I said that.
Yeah,
I should have
history of
practiced upon that in that 2 minutes.
Yeah, history of contraception was asked, cesarean section history was asked, history of epilepsy was asked. Then you completed your template, that was fine. The history taking was all right, Divya. Keep going and practicing that. You know the concerns behind sterilization. You did do that. You did mention about the pros and cons of each option, and indicators of regret were also there.
Okay.
Now, I would like to say in this patient, she was Julia. Julia, I understand and I respect your concern. Tubal blockade is indeed the most appropriate choice, as the chances of failure are very less. And for the women who have completed their family, indeed it's the best choice. I have few concerns regarding that. Can I discuss with you? I appreciate that you have decided this for you. However, at times we see patients who are less than 30 years in case of a change of relationship, a new partner who desires to have kids in future, or at times the existing kids unfortunately have some health situations for which women come to us and they request for the reversal of the sterilization. I'm afraid if this is a desire in future because of some unfortunate, unavoidable circumstances, this would not be refunded by the NHS. And secondarily, even if reversal is done, the chances of successful pregnancy is very less. I just wanted you to reconsider and think about it before you take this decision of permanent blockade of the tube. That's it.
Okay.
Now I will take a pause. So this is not, I'm saying that she would have the loss of relationship. I'm not saying that she would have some problem with the existing children health. But yes, we see patients, they come to us. So we just have to give her this piece of thought in her mind.
Okay.
That this may happen in future. So now I would say, I can offer you ways which are almost equal in the success for prevention of pregnancies, and provide you a long-term contraception if you're okay with that. Can I proceed? So now I would be coming to this. So what did I do, Divya? This is an ideal way of negotiating. First, I appreciate the sterilization. Then I told my concerns about sterilization. Then I came to the alternatives available. Now she is ready to listen to this. Okay?
Okay.
So I would come to the male sterilization. If we talk about the permanent methods, I would do it in the start because it's an alternative. And if your husband is ready for that, the blockade of the tubes from the husband's side can also be done. However, this requires his consent and we can talk to him if he agrees to that. The other options which we have is a copper coil, a hormone coil, copper T, you don't have to say, okay, copper coil, hormone coil, the progesterone rods in the arm, and the progesterone injections which we give 3 months.
Okay.
Do you have any concerns regarding any one of them, or do you have any choice out of these? So now when I'll come to copper coil, I'll give 1 pros and con, hormone coil 1 pros and con. When I'll come to the rod, I'll say because of the medicines you are taking, it is not suitable. We suggest that the injections or the copper coil or the hormone coil is chosen for such patients with the same condition. So now I will come to the long-acting reversible contraception out of 3. My point is that don't miss out Implanon from this and say LARC are only 3. LARC are 4.
Okay.
But out of that, why Implanon is not being chosen? This would be your applied clinical knowledge. Got that, Divya?
Yes, yes.
Okay, very good. Well done. So female sterilization, you can simply note few lines to explain all of you that how do we do that. This is a minor operation and many women return the home the same day. And it's by applying clips, applying rings, and tying, cutting, and removing a small piece of the fallopian tube. Now, do mention this thing that NHS does not fund the reversal of sterilization, friends, right? About the copper coil, you can simply say the pregnancy rate is less than 20 in 1,000 over the 5 years' time. And it does have few risks like having infection and expulsion as well. And in future, if the pregnancy does happen, it can be in the tube as well, right? Similarly, for the hormone coil, you can say it's less than 10 in 1,000 years. And the same complication rate as that of copper coil are also there. Now, this is the hormone device which is placed as a plastic rod in your arm. And that has very low failure rate, less than 1 in 1,000 over 3 years. And there's no evidence showing a delay in the return of fertility. However, the medicine you're taking, this might not be suggested as the first line for your condition. These progesterone injections, it has a very low pregnancy rate, less than 4 in 1,000 over 2 years, and it is repeated in 3 months' time. There's a delay in the return of the fertility, but this is not a concern for her, so that's fine, right? Now, another thing which is important here is that it also reduces the risk of the seizures. So if you remember for the part 2, the book of mastering, there was a question in which all things are given. So DAMPA had been chosen. So DMPA, otherwise in epilepsy, has dual effects like benefit in terms of long-acting reversible contraception at the same time, reduction in the frequency of seizures as well. So you all can just note down 1 or 2 points from here. So do the introduction, make an agenda, take information gathering, check the concern regarding request, tell her the management options. Please start from the appreciation of the one she requires first, then tell the concerns regarding that and the regret options, then come to the alternative, starting from the permanent male vasectomy, and then telling about the 4 long-acting reversible contraception, and in the end giving her PIL and telling her to come with a decision. In this situation, if you're doing a counseling and you make a patient come step back from the sterilization to the LARC, you are successful. So if she takes time to think and reconsider her decision, you have passed your station. So you should, yeah. so you should just remember. So you should just remember that the lines you have to make to tell her about the chances of regret at this age, right? And they were beautifully spoken by Divya. You can also note down my lines and just cram it up, mug it up, and simply speak it. Try and practice it more and more. I will give you 2 by 2 in information gathering, Divya. I will give you 1.75 in communication with the patient. Because of jargons, I'll deduct few marks. In applied clinical knowledge, just be in sequence, right? One after the other. Don't miss out the things from in between. I'll give you around 1.5, 1.7. And patient safety, again, that was almost passing. So all as a whole, the station is passing station. Well done, Divya. And very, very good attempt. Good communication. Work on avoiding the jargons and work on a good flow in the information gathering as well, and a structured applied clinical knowledge. Very well done. So group D goes great today. Group D goes great today. Harshiba and Divya, very well done. I'm really happy for all of you. And I'm sure Bindu, Pallavi, and Dipti all would be doing great as well. Very good.
Our group, we always, we practice every day at night. Almost all of us take turns. We present 3 to 4 stations a day. And every single day in the last week, we have never been able to complete any station within 14 minutes. And today we are so glad because both of us did it within 10. So
very good. I understand. This happens in actually doing the station, but I'm glad this is going to help you all. See, Divya,
yes.
when somebody is speaking and you are listening, you learn a lot by this, you know, the mistakes and things they come into your mind. And, you know, when you're sitting in the cubicle, this is my personal experience, that things that are coming into your mind the way you are discussing. So this practice would really help you guys, and I'll ensure that till the exam day, these mini groups, they stay alive and you people keep on practicing in this manner, and this is going to be a very good help for examination. I'm sure for that. Thank you very much. Keep going, my dear, and keep working hard. Every next station should be better than the previous one. All
Yes.
right? Okay.
Dr. Deepti is asking if we have to explain in detail about all the methods of LAC while discussing options.
Only pros and cons of each, because otherwise Dipti's station would not get completed, my dear. Only pros and cons of each, and ask her if she wants to know detail about it. If she has made her mind, she will direct you. Can I know more about the Hormone coil, doctor? So then she's directing you in station. Then stick to that. Okay, sure. So if she has a plan for hormone coil or a copper coil, then she is going to direct you towards that station. Okay, yeah, Dipti, got that? Okay, thank you very much. Right. So let's move to the sixth station. Very well done. So now we are going to have Sarvat. Yeah, hi Sarvat.
Yes. Yes, hi, how are you?
I'm good. How are you?
Fine, now tired. Maybe an experience in the exam also to getting tired in the last stations.
See, remember, your energy till the 14th station should be perfect. And I'll work on this not getting exhaustive. I used to do like 14 stations in a go in last 15 days, one after the other, like 14th circuit and then 14th circuit.
Yeah,
So
we need that
remember,
practice also.
yes, we'll inshallah make the stamina so that it goes well in exam, right? So now we are having a change in the station and we'll go with this ST. Go ahead.
Okay. Can I see the first slide again? Okay. Any other slides?
That's it.
Hello, I am Sarvat, one of the exam candidate, and I am ready for the discussion.
Right. So, Sarvat, we are going to discuss the case today. Can you tell me that for this 9-year-old girl, what do you think is the diagnosis in your mind?
So this is a case of a young girl in accident emergency with urinary retention and some ulcers also. So my concern are about the sexual abuse, child sexual abuse, and having some sexually transmitted infection with that.
Mm-hmm.
And there can be some.
Yes.
Yes.
What will be your response in this situation?
So first of all, as the child is presenting with a urine retention problem and pain also, so first of all, to make her comfortable by doing the aseptic catheterization and giving the pain relief also if it is needed, and then I will go for the information gathering to take some information from her mother and also from the girl alone, if it is possible. So from the mother, after taking consent, I will take the information about the child, since when she is having this and is the ulcers are for the first time, and or she has any complaint before also, were there any previous episodes, and was there any discharge, any history of fever to rule out the infection, and any bleeding from vaginal bleeding, and any previous treatment if she has taken before, and about the urinary complaint of the child, if she is having any burning or stinging in passing urine, and when did she pass urine last time, and any previous episode of retention of urine if she had, and any previous urological problems, and any bedwetting recently to rule out the if she has got some because of sexual abuse, she has got any trauma and some new change in behavior, any bowel discomfort or any recent swelling, and after this about the child's any unusual change, recent change in behavior, and is she having any other medical when was if the child is 6-year-old, if she is starting having any periods, in case of thinking about precocious puberty, and regarding any medical comorbidities and allergies she has, and about the social condition of the house, who takes care of her, and what are the home circumstances, what are the relationship between the parents, and is she attending the school, how is that going, and any other mental health issues child is having, or about the child, is she adopted. This is about the information, and then I will go for examination and I will take some time if the child, I can speak with the child alone also, and then examination in the presence of nurse chaperone with the consent of the mother. First of all, I will reassure the child and make her comfortable, and look for the general examination, and then the local examination of the genital area to see for the any bruises or any the ulcers which are present, and the bruises or any sign of violence there, and with that, if there is any discharge, we need to take some swabs and urinary investigation to take urine dipstick to rule out the infection, and swabs for the herpes and other bacterial infection. And I will explain to the mother sensitively that we are suspecting the sexual abuse, and I ask about her ideas about it, and and after that the treatment of the child for the for pain like paracetamol, and discussion with the pediatric team, and if she need admission in the pediatric department, and also gynae under the gynae care also, and with the pediatric team will decide about the the treatment of antibiotic or antivirals according to for her herpes, and if there is any infection also, and for the care of her local hygiene of sitz bath, and pain is there to use the lignocaine gel.
So where do you plan to admit this patient?
She will be admitted in the pediatric ward, but under the pediatrician care and with the gynae cover also.
Okay. So what other specialities you need to involve in this care?
We will involve the pediatrician, gynecologist, and genitourinary medicine also. Clinic if she is having sexually transmitted infections are there, and for her child safeguarding and child protection team, and social services also.
Okay. So what further management plan do you think after some initial aid to the patient after admission you need to do for this child?
Yeah, further management for the for her, if there is a about after the investigation reports and everything, for her as I discussed, the child safeguarding and protection issues, and her check for the sexually shared infections for chlamydia, gonorrhea, and hepatitis B, C, HIV, and VDRL. And if she need hepatitis B vaccination, if it is not done before, the accelerated schedule of vaccination of 0, 1, and 3 weeks. And if she need HIV prophylaxis, and repeating the test again after 2 weeks and 12 weeks, 2 weeks for chlamydia and gonorrhea, and after 12 weeks for the hepatitis B, C, HIV, and VDRL. And counseling is important for the child.
All right. So now this girl declines inserting the catheter and she is not ready for any sort of swab taking. What will you do?
For catheter, we can first counsel the child, make her comfortable, involve the pediatric team in that, and catheter can be, we can apply the local anesthetic to make her pain free, and use a small catheter of 12 French under aseptic technique, or if it is not possible, we can use suprapubic catheterization also, and swabs can be taken on later when the child is comfortable.
If she's not comfortable even after the numbing cream?
I can involve the pediatrician, and can be taken under with IV sedation.
Yeah. So what is safeguarding? What do you understand by child safeguarding, please?
Child safeguarding is involving the multidisciplinary team that, the specialized individual that will take care of the child if she is not safe at home, or if she is at a risk of further exploitation or sexual or drug abuse, and involve the child psychiatrist also.
Okay. Anything you would like to add in any of the question? You've got 20 seconds, yeah?
And involve the school also to ask about the child, how it is having there, how the things are going on there, and help the patient, help the parents if they have any financial problems or yes, that's all. Okay, thank you for your time.
Let the bell ring. You're telling the examiner that, okay, it's done, huh? Let me leave the cubicle. All right. Thank you very much, Sarva. Thank you. I know it was a difficult station, and you spoke a lot of this station. In exam when this station came, students were blank. They didn't know anything for this station, and they were like, what to say in this station, what type of station.
No, I wrote this station in my own words 1-2 times, and I read it 1-2. This much I know, only this much what I spoke.
No, whatever you have spoken is very good, because now if a repeat station comes like this, it is going to be an easy one. When it comes for the first time, even my students, they were saying that, ma'am, when it comes as like where you're going to admit this patient and all, they were all blank. That what do they want to know in this, and they were blank in the management plan, because of course 9 years old girl, we are not able like to handle in such situation. So this type of structured discussion, there are again few in these exams, but you did really well. Now that means that you have prepared this station, because the way you were answering were those things which had been searched. It can be done for this question number 6. You were fumbling a little, Sarvat. It can be done under a simple inhalation general anesthesia. So for a simple sedation,
it was coming in my mind, IV sedation. That's why I said in the end IV sedation.
Yes, yes. It is actually sedation. You simply sedate for like 2-3 minutes. Your job is done, and the baby, the kid is awake, right? So this is one thing which you, I wanted to listen to from your side. Child safeguarding means that everywhere you're going to protect that. Like I've got at salt station. Let's do the salt station now. Your patient safety and applied clinical knowledge. is passing even communication of the colleagues. This is a very well done station. It's not that something which was coming in your mind and you were speaking that it seemed that you had prepared this station. Well done, Sarwat. The diagnosis was a case of sexual abuse in a young girl. I would also add in herpes in that because it's blister urinary retention. So I will add in this saying that it is evident from the history and examination that it is a herpes infection as well in the child. The next step, when they asked about, always remember it is going to be a multi-agency referral in the beginning. It is a serious issue. It can be a case of a sexual assault, specifically when the child is not having an inhibition in the examination. There is need to involve the police, child protection service, social services, safeguarding agencies, and the consultant on call immediately. The patient needs to be re-examined to confirm the findings of the general practitioner and requires admission as well so that appropriate investigations and treatment can be offered. This admission is going to be in the pediatric ward. Very well done. Students were confused in exam for this answer. The involvement of the specialities would be a consultant pediatrician along with my consultant gynecologist, and consultant adolescent gynecologist would also be taken into consideration to manage this kid. Okay. The blood samples to check for the HIV, HBs antigen, syphilis, the full blood count, C-reactive protein, antibodies to herpes simplex virus to know whether it's a primary infection or a recurrent infection is there. Would also send the vaginal swabs for the other sexually transmitted infection, and the kid would be catheterized, the girl would be catheterized to relieve the pain for the full bladder. All the chain of evidence would be collected to rule out the sexual assault. The child will be given the analgesics, antibiotics, systemic and local antiviral after discussion with the pediatrician to adjust the doses according to the age and the weight. Right? Now, if she has started periods, it was 9 years, Sarwat, not 6 years. Yeah. So 9 years can have periods, okay? So precautions, puberty thing, we can just take it out. So if she has started her periods, we might think of the emergency contraception for her. We'll make her comfortable and ask her what actually happened and take a detailed history. And if she knows the culprit, has she been threatened to get some gifts, and how long this all had been happening, would like to know in detail from her. Whether she has informed any family member. What was the reaction of a family member? Does she have other siblings? Are they at the same risk? Was she ever intoxicated with drugs and alcohol before such event? Is she attending the school regularly? Now, I have concerns the information provided to me regarding the mother's response to the situation. Would like to know the relationship of the mother to the child. Is she an adopted child? Right, Sarwat? Because it's written somewhere, so we have a query whether she's an adopted child. So maybe mother is using the child because she is in a hurry to take her back home. So this is a clue which has been given in the candidate instruction. I will explain her that I will not hurt her in the examination. First, apply some medicines to ease her local pain while catheterization. I need to insert catheter to relieve the abdominal pain, and applying gel would be my first step to make the area numb. Would ensure that it's the smallest size catheter of 12 French after lubrication inserted. If still she's not comfortable with that, we can have a little sedation with the general anesthesia and then take the swabs and insert the catheter for this girl. Now, if she declines for the vaginal swabs, again, we'll take some time to make her comfortable. This girl requires psychological support as she has gone through a lot at this young age, and she's at risk of further exploitation as well, the risk of drug abuse, the risk of sexually transmitted infection. This has future implications on her fertility, the flashbacks of abuse, and she might have social withdrawal as well. Just cram up these lines in the end that this is the risk for the child. Now, she should be encouraged to attend school and return back to the normal routine, and need to involve the child's psychiatrist to deal with these conditions to bring the self-esteem and the confidence back of the child. What is child safeguarding? So what child safeguarding is that the child has to be safely living in all those environments where she goes. So child lives at home. So we have to look at the parents' relationship, their financial aspects. Child goes to school. We have to ask, how is her conduct at the school? And do teachers or the friends at school, do they notice some sort of different behavior, or she has some threat in the school? And we involve the general practitioner. Why? Because he's the first person to look at the child whenever she has some problem, right? So the first thing is inside child safeguarding. All those areas where child goes or child has an approach to, they all would be involved. So after admission, involvement of the general practitioner the next day to know whether she has had previous admissions in the hospital or whether the health visitor has had any concern in the past. And then call her school to ask about how is her conduct at the school. Now, would like to know whom she's living with at home. Any sort of male like cousin, brother, and uncle who is trying to have this relationship or threatening the child. What is the financial status of the family? What are the parents' occupation? Do they require any support? Right? So this type of questions would be in the child safeguarding, that from all areas, all the four corners, child is safeguarded from home, from GPs, GP should be knowing, from the health visitor side, from the school side, and there is no place where there's some threatening. So child safeguarding means safeguarding the child from all the areas, right?
Yeah,
got that? Okay.
Yes.
Okay, very well done. I'm really happy with the structured discussion. So next time we'll be giving you SPT. This was a difficult station, friends. Anybody else who prepared the station in the same manner as Sarvat has done? Sarvat, you presented the station in the mini group, or it was your self-preparation?
No, I did not present, but I shared the template.
Okay, okay, very good.
Which
so
I made.
Okay, so that was your station given to you, huh? Okay, next time I'll ensure the stations which you give to others, I give those stations, huh? So that I can see that this
No,
one...
that station was not given to me.
Okay,
I just
you
prepared
just
it.
shared. Okay, that's perfect. Well done. So that is an extra work you did for your mini group, huh? Yeah. Thank you very much, Sarvat. Well done, my dear.
Okay.
Keep going in the same manner. All of you, yes, Bindu, it was beautifully done station by Sarvat. You all have to remember, just cram up this salt station. Please note down this station, because if this station comes randomly, you people are blank in that what to speak and where to speak. So just go in this organized manner and beautifully do this station. You won't be blank in exam. Thank you, Dr. Sabiha. Well done, Sarvat. So buddies are happy as well. Thank you. Okay, so let's move to the station number 7. Dalia. Hello.
Dr. Sidra.
Yes.
Dr. Sidra, I'm having one question. Hello.
Yeah, your voice is not audible. Yes, please.
Dr. Sidra, when the second question in the structured discussion is what will be your next step?
Yes,
so can we frame it, because the girl came in with pain and urinary retention. So first I'll make her comfortable and give her some painkiller and trying to drain her bladder. I mean, in the lay language. And then we'll go for history asking
information gathering and examination. Yes, my dear. The first step is always making her comfortable. Correct.
I think I said that the tension of urine first relieve that, and then painkillers.
The first thing Sarvat said was will make the patient comfortable and catheterization to relieve the bladder pain, and then we'll start with the information gathering. Yes. Okay. All right. Thank you very much, Devti. Thank you. Hello, Dalia. How are you?
Yes. Hello, Dr. Sidra. Hello.
How are you?
Fine, thank you.
Oh, that's great. So you must be tired till the last station, huh?
Yes, a little bit.
I understand. So I respect that. Let's begin with the station. So now, friends, what is left? What is Dalia getting in the station, huh? Let's make guesses. What is going to be the station?
Let's operation with the...
All right. So let's begin, Dalia. Let's see. What do you have? Go ahead.
Okay. Okay, next. Okay, next.
That's it, Dalia.
Okay, can I start?
You don't need your 30 seconds to organize yourself. It's okay. It's okay if you want to start.
Okay, I just will close the door, okay? Because there's some noise outside, so I'll close the door, okay?
No problem, no problem. Take your time. Again. Okay, I think Dalia is coming back, friends. So everybody, please solve your station till Dalia is presenting. Please note down your points, and because it's a repetition of emergency contraception as well, along with LETS. So let's see how do we handle this station. Okay, Dalia, are you back?
Yes, Dr. Sidra, sorry. Sorry.
No problem, sweetheart. No problem at all. Please begin. Yeah.
Yes. Hello, I'm Dr. Dalia. I'm one of the treating doctors in the colposcopy clinic for today. May I confirm your name and age, please?
Yeah. Hi, doctor. Dr. Amanda Rogers. I'm 34 years.
Well, how would you like me to address you?
Amanda is okay, doctor.
Okay, fine. Well, I can understand from your case notes that you are here today because you're coming for the LETS because you have a CIN. Am I correct?
They have to take some loop sample, yeah. So
okay.
I had some abnormal cells in the neck of the womb, yeah, doctor.
Okay. And also, do you have any other concerns?
That's it, doctor. I actually had unprotected sexual intercourse basically yesterday and 3 days back. So I'm a little concerned it has nothing to do with the loop treatment, right? So I was a little concerned. I just had it like 3 days back and then yesterday as well. Is that okay to continue with the procedure?
Okay, so you had an unprotected sexual intercourse yesterday and the day before, or?
Yeah, 3 days back to yesterday, yes. Maybe 4 days back from today, yeah.
Okay. So for sure we will come to your concerns and we will discuss together a mutually agreed plan. But first, let me, if you don't mind, ask you a few questions to know more about you. Okay?
Yeah.
Well, can you tell me more about your periods?
Yeah, periods are fine. I don't have any problem with the periods. Periods are going okay, yeah.
Your current day of the menstrual cycle?
That is 15th day.
Okay. Okay, and is it regular?
Yeah, I have my periods around 28 days.
Okay, and for how long does it last?
For 6 to 7 days, I bleed, doctor.
Okay. Okay, I'm sorry if you find some of my questions intruding, Amanda, but this will help me to provide you with the suitable choice. You told me that the unprotected sexual intercourse was happened yesterday. Is that right?
Yeah, and also 4 days back.
3 days back.
Yeah.
Okay, and what exactly happened, Amanda?
Actually, the condom didn't work. I was with my husband, and we practice condoms generally, but actually I just saw that there was a tear in the condom, so it was, I was worried. Yeah.
Yeah, so you're using condoms, but you think that it didn't work. Okay, and do you may I know precisely how many hours has passed from the last
The last one was 18 hours back, and the previous one maybe like maybe 96 hours, doctor.
Okay, and you haven't received any emergency contraception?
No, nothing, no.
Okay, and you're not on any form or using any form of contraception at the moment?
No regular. I'm not on any regular, and condoms too we use on and off.
Yeah, okay. And so, and are you willing to continue on contraception, Amanda, or not?
Yeah, that's fine. I mean, I don't want a pregnancy. I don't plan a pregnancy at all. My family is complete, doctor.
Okay, so you're happy to continue on contraception if there's option. Okay. And I would like to reassure you that whatever you're going to say will be kept in between us in this room. So can I ask you what was you with your regular partner, Amanda?
He's my husband, yeah.
Okay. Have you ever been tested for sexually shared infections?
Yes, doctor. I was told that I have that viral infection of the neck of the womb. For that, I was just being treated for this loop cutting, they said.
Okay, and you have been received treatment for this, or you haven't?
I'm going. Yet? Yes, I'm just planned today for this loop piece cutting from the neck of the womb.
Okay. And have you ever been pregnant before, Amanda?
I've got 2 kids, yeah.
And was there any problems in the previous?
Everything was fine. Everything was fine.
Okay. I want to ask you. I'm sorry, Amanda. I should have asked you before. Do you have any bleeding in between your cycles or after sex?
Yes, I used to have that, doctor, but now it's okay. I'm just planning for this treatment. Then they diagnosed me for this abnormal cells in the neck of the womb.
Okay, so you have got this. Are you otherwise fit and well?
Yeah, I don't have any other issue.
Okay, and are you allergic to any medications?
I'm not.
Or to anything?
No.
Such as copper or nickel?
No.
Are you on any medication at the moment? Okay. Have you ever had any surgeries before in your tummy or from down below?
My 2 cesarean sections, that's it.
Okay. Do you have any family history of concern or anything you want to
family is fine.
tell me about your family history?
No.
Okay. What do you do for a living, Amanda?
I work as an accountant in a company, doctor.
Okay. And is everything okay at home?
Yeah.
Your husband is supportive?
Yeah, he is.
Okay. Well, how cigarettes per day, Amanda?
Maybe 3 to 4.
Hello?
3 to 4.
Okay.
Okay. Take a detailed management plan. Adopt that answer.
And would you like to? Hello.
Yes, Talia.
Have you ever thought of quitting smoking?
Yes, I can hear you.
Do you hear me?
Yeah, I will think about that, doctor.
Okay. Do you drink alcohol?
No, I don't.
Do you take any recreation drugs?
No.
Okay. Do you know the ratio between your weight and height, Amanda?
Yeah, that's fine. That's normal, doctor. 22.
Okay. Thank you for sharing information with me. And do you want to add anything else, Amanda?
No, that's it. Please tell me that what is the management plan for today?
Okay. I would examine you from down below, Amanda, after your consent and in presence of a chaperone. We may need to take some swaps from down below.
So what is the plan for me, doctor? What emergency contraception suits me?
Hello? Hello?
Yes, what emergency contraception suits me, doctor?
Hello?
What emergency contraception suits me, doctor?
Hello? Yes. Monday. Hello?
Yes, Dahlia, we can hear you. What emergency contraception suits me, doctor?
Hello?
Yes, Dahlia, we can hear you. Hello?
Hello?
Yeah, Dahlia, we can hear you, my dear. We can hear you. Dahlia. Hello? Dahlia, are you there? 9 minutes and history is yet to be completed. Anybody's here from the group B? Anybody's here from the group B? Dahlia, can you hear me? Dua? Nadra? I know Midat is not here. And Salma is not here. She was on duty, right? Okay, anybody would like to take over for the management plan, though 10 minutes are over. But still, if...
Hear me?
Yes,
Hello?
Yes, Dahlia, we can hear you, my dear. We can hear you.
Because I just lost connection. I'm sorry.
No problem. No problem. Yeah. No problem, Dua. I understand that. Okay, no issue. No issue.
Okay. So she was on day... she told me she was on day 11 or 15. I can't remember.
15.
15, okay. So shall I proceed, Dr. Sidra?
Yes, please do the management plan. Yeah.
So management, we have let me draw for you. This is your womb, and this is your tubes and the ovaries, and we have two options: either the morning after pills or the copper coil. The morning after pills, we have two types of morning after pills. They act by delaying the release of your eggs, so that you don't the eggs don't meet the sperms, and so the eggs will not be able to be released, and so will not need the sperm. The success rate of these pills is 98 in 100. And the other option is the copper coil, which acts by preventing the sperms from meeting the eggs. And the success rate of the copper coil, if it's inserted in the correct position, is then 99 in 100. And from your history, Amanda, and since you are on your 15th day in the cycle, so you are about more than 2 weeks away from your last menstrual period. So the ovaries are likely to have released your eggs. So the pills may not be suitable for you, and so you will be offering you will be offered the second option, will be more suitable for you, which is the copper coil.
Okay.
Do you want me to tell you more about the copper coil?
Yeah, I just wanted to know whether you're going to just place it today or it's going to be like after the procedure.
Yes, we have 3 options. Either to insert the coil before the LADS, the operation, or to insert it after the operation, or to postpone the operation for 2 weeks, and then you to insert the coil first, then come back after 2 weeks to do the operation. I will tell you the pros and cons of each option. Okay.
Okay. Yeah.
Okay. The first option is to insert the coil before that's operation, and this means that we are going to insert the copper coil from down below through the neck of your womb to the inside of your womb. This coil is a T-shaped plastic device which has threads from down below, which helps us to remove the coil easily. Okay, are you following me, Amanda?
Yeah, I am. Okay.
So after, if we inserted the coil before the operation, these threads may become burned and damaged after the operation, and this will make us unable to remove the coil easily, and this may require a telescope in order to which is a camera, in order inserted from down below in order to see the coil and remove it easily.
All right. So what if we just postpone the procedure today, doctor?
Yes, if we postpone the procedure, you will be we will make the operation. We will insert the coil today, and we will proceed the operation after 2 weeks. We have 2 options if we have done this. Either that if we was sure that you are not pregnant because we have done a pregnancy test and it's negative, so we can remove the coil and then do the operation. Or the other option is that we will not be you will not be sure that you are whether you are pregnant or not, because if your period is late. So if we are not sure about that, we will do the operation while the coil is inside, and this will carry the same risks I told you before.
I understand that. Okay, doctor. So you can go with the procedure and the copper coil. I don't have any problem with that.
Okay. So you want me to insert the coil and do the procedure after that?
Yeah, that's okay. Yeah.
Okay, and it's okay for you if we use the camera to remove this coil again?
That would be all right. Okay.
Okay. Okay.
Thank you very much, doctor.
Do you want to ask about anything else?
No, thank you, doctor. Thank you.
Yeah.
Okay, all right. Yes, Dalia, how was the station?
It was fine. It was just the bad connection. I'm sorry for that.
No, that's okay. History taking took a lot of time. It took around 9 minutes, and that's not acceptable, right? Be a little quick in the history taking. You have to practice history taking, that the questions should come up to you quickly, like one after the other. Okay, you know the questions, but like too many pauses in between the questions, they tend to make your station get completed in time is difficult, right? 4 minutes maximum, 4 minutes. Okay, so you have to send me a voice record in your mini group. A doing station with anybody, take anybody from the group and do the station just again with the time management, keeping a clock in front of you, like 4 minutes information gathering done. And then next, it has to be like complete management plan in next 4 to 5 minutes. Your management plan was right. I remember we discussed this template in the mini group as well, right? Yeah, when we were preparing that. But the communication was fumbling. That we have to improve on the speaking again and again. I understand the difference. I understand the language barrier, but all Arabic people, they have been doing with me with this communication, making it smooth with practice. And definitely we would do that. Even take contact with Salma and tell her that to do this station with you, she'll become your role player. Be quick in asking questions, like one after the other. Don't take so many of pauses in between, like even 15 seconds were there. So these are way too big pauses in an exam station. 10-minute station has to be a quicker. You need to give pauses at time, up and down in sound and voice. It has to be there. But if you give too many of pauses, then it seems that you're not prepared to the examiner. We have to give this impression to the examiner that we are well prepared. All right? Okay? So you'll manage to do that, but we'll rehearse that again because there was some connectivity issue. So in the mini group, you'll just send me the voice record and I'll just see that how improved the speed is there. All right? Okay? All right. So for the management plan, one more thing in the introduction, don't say the jargons as I told Divya as well. Right? Like Divya said that you're here for the laparoscopic sterilization. Similarly, you said you're here for the LETS, for the SEN. Yeah. So this was the same thing, the same mistake which I told her. So you have to say that, yeah, I have gathered from your case notes that you're having some abnormal cells in the neck of the womb and you're here for the procedure today.
Okay.
Am I right?
In the procedure today. Okay.
Okay. And
okay, I thought that the patients are aware of these words.
No. Patients are not aware of what LETS is and what SEN is, huh? They're not aware of that. Okay. So what communication with the patient, we need to improve that by making less pauses and less fumbling. We need to improve avoiding jargons and being a little fluent. I would like you to be a little more fluent. Otherwise, yeah, asking question was fine, but it was coming with a delay.
Okay.
So this has to be improved. History of presenting illness would have been started with the LETS. So may I know that I've gathered about the abnormal cells in the neck of the womb. So may I know the details about that? And then unprotected sexual intercourse. These two things were your current day of menstrual cycle you asked, and you also asked about the number of hours passed from the sexual intercourse, if there have been 2. So the pill automatically goes aside. So it's the copper coil after 15 days, right? Menstrual cycle history, you had to ask in HOPI. So these 3 were your HOPI question. Of course, sexual history as well, because you're inserting a copper coil. So that too came way too late. When you asked even after the husband and HPV, that was around 7-8 minutes we had reached. And when we reached alcohol smoking, it was 9 minutes. So this time management, this is difficult. If we have to reach to management, it should be a half station, like half in the information gathering and half in the management plan. Okay. Then you came to the gynae obstetric history medical family template was fine, but it was taking too much of time. It was not coming to you spontaneously. That shows that the practice is required. History taking, I gave you in the first station. So I want that everything is like, one after the other. It comes to you one after the other. Okay. Then examination had to be done. Why? Because we are inserting a copper coil. So HVS had to be done. Now, concern was about unprotected sexual intercourse. So the suitable contraception for her was copper coil. Delaying LETS can cause worsening of the condition. That was important. And chances of unwanted pregnancy can always be there because of the failure of the contraception. In the management plan, you would say, Amanda, we've got 3 options today. Now you know that she's at 15th day. The emergency contraception is the first thing for which we have oral pills and we have the copper coil. Since the oral pills, they work by inhibiting the egg release from the ovaries, and we presume because of your 15th day of the cycle that it has been done. Therefore, the management option which suits you in terms of emergency contraception, it's the copper coil. Along with that, we have to deal with this loop cutting of the neck of the womb of the abnormal cells as well today. Now we've got three options. The first option is that we insert the coil before doing this procedure today, but we have some problems anticipated as possibility of cutting of the threads. And then there's a misplaced coil for which we require a telescope and a camera for misplaced coil, and we have to remove it under anesthesia in future when it is required. The second option is that we insert the coil after doing the procedure. Now the chances for this is the infection is more, for which we will give you antibiotic. Just wanted to discuss you the anticipated complications. The third option is inserting coil and not performing the procedure today and reschedule that. In that case, I would like to tell you that the risk of delay in the diagnosis of the abnormal cells, we miss out some sinister changes at this point in time. How do you feel about that? Now give her an opportunity to ask questions and decide for herself. You have given the pros and cons of all the three options available today. So the first part in question is that she should be knowing that we are dealing with two things in this station. Number one, emergency contraception and the LETs. If she's in the first cycle, yes, you can give pills, that's not a problem. But they specifically gave second half of the cycle. Why? Because the copper coil and the LETs procedure both have to deal with the neck of the womb, right? Now, when you come to the procedure, you say that we've got three options in a systematic manner, that either we insert coil before the procedure, we insert coil after doing the procedure, and we insert the coil today to prevent the unwanted pregnancy, and we reschedule the procedure today. Tell her the pros and cons of each. Now, whatever she suits to her, you just go by that. Am I clear?
Yes,
This
doctor.
is the options available, my dear, which you have to remember that in exam, give her all the three options for these procedure and go side by side that this be what we can do today. So whatever suits you. If she's ready for this, just insert the coil and do the procedure. If she's ready for this, do the procedure, insert the coil, and tell her about the cons of this as well, that rescheduling can put you on risk as well. So whatever she decides for herself, you're going to offer all thrice of them.
So I explained, I think, but I don't know if you have heard me or not, Dr. Sidra. I explained for her that she has the option of pills or the copper coil, and I explained
the only point was, I totally respect that. Yes, Talia. The only problem was that this came around in 12 minutes time. So we have to shrink it till 10 minutes, right? Because the marking would be over at 10 minutes. That you explained all these three options. I respect that, but they came way too late. I want that we shrink it like within 10 minutes. Huh? Explanation was absolutely fine. So pauses, take less pauses, be a little fluent, and squeeze it in 10 minutes time. Okay, my dear? So we'll work on that, and tomorrow just send me a voice note there so that I can see that now it is within 10 minutes. So keep a clock in front of you and then do a station. All right, my dear? Okay, coil insertion after LETs can also lead to bleeding and fragile cervix after LETs. Yes, chances of infection and bleeding. Yes, Girija.
Hello, Dr. Sidra. I want to ask one thing. The station can come like variability. The patient came just like for LETs today and to explain the procedure, answer the concern, and then hidden agenda is UPSI there, this unprotected intercourse, when we talk with the patient. So then we have to explain two things about the LETs also and about the emergency contraception.
Yeah. So you have to tell about both the things because this is a change in this procedure. Now she says that I'm here for the LETs, and now my concern is that I had unprotected sexual intercourse. So you'll take the station in the same manner. History of unprotected sexual intercourse, knowing about the day of the cycle. Now, what does it suit? If pills can be taken, you'll give the pills. If pills cannot be taken, then you'll give the copper coil. Then three options of copper coil insertion would be there. Got that?
And after that, we have to explain the LETs procedure also.
Yes.
Because she came for that.
Yes. No. If she has been decided, Sarvat, for the LETs procedure, then explanation part should have been done. Then you ask Are you aware of the procedure to be done today? Because if let's had been decided today, so that means that she was discussed about this earlier, right? Right? So you check her understanding. Are you aware of the procedure you have to undergo today? She says, yes, doctor. They won't put too many things in 10 minutes, like unprotected sexual intercourse, emergency as well, and then explanation of let's as well. If she says, no, doctor,
okay.
Yeah, if she says, no, doctor, I'm not aware of that, then you can speak up 2-3 lines. But I'm sure they'll not put like 4-5 things in one station because you're fighting against time. If this is decided today, so she's coming up with her mindset today, right? That today she's going to have less.
And if patient has any planning of pregnancy in future, then we will talk about the effect of this. Yeah.
Yeah. Okay. That this future. So if it's not there, then basically she's completed her family, then stick to these 3 options. So they'll give you 1 or 2 agenda, maximum 2 agenda. More than that, they'd never give you, and that too in one station. Generally 10 to 12 stations are very straightforward stations. Okay. Any questions, friends, from the lead station, that how it would be in, this was again being discussed so many times earlier in many groups, but just remember that these 3 options you have to give, and then put the decision on the patient. Okay, put the patient's decision into consideration, that all 3 options are with you. What suits you best, the pros and cons of each. Done? Any questions, please? Yeah, somebody has unmute mic. Yeah, I'm open for the questions, please. Yeah. No? Okay, okay. Thank you very much. Thank you. So Dalia, I'm going to mark this this question, this station again tomorrow when you send me the voice note. Then I'll mark your station. All right. Okay. Information gathering, communication with the patient safety, applied clinical knowledge, when it would be like within 10 minutes. All right. Okay. So this was the outline, and next week on Saturday, we are going to do the early pregnancy care. The basic template I'm going to give you today. So are we done with the sexual module? Any questions regarding the module, please, before I go to the next template? Girija, Dua, Ramya, Dua is on duty today. Did you learn something? Sujata, Dr. Sabiha, Dipti, Sarvat, Bindu, Harshiba, Jyoti, Liana. Oh, must be very late, Liana, at your part, I know. Rahma, Ramya. Okay, Sarvat. Sarvat Awais, you are silent today. Okay, thank you very much. Yes, that's important. We are going to have long sessions in this. Thank you. Okay, so let's go and see that early pregnancy template, how we are going to do that. Thank you, Pallavi. Thank you, Dipti. Introduction agenda, history taking, you will start. Now, if the complaints are bleeding, you will ask about since when this bleeding had started. What is the amount? What is the color? Are you passing vesicles and clot? Associated pain? Is it started after 6? Fainting episodes? Are you feeling dizzy? To rule out ectopic. Thank you very much, Rahma. I'm grateful. Since when it started, describe the pain. Does it get worse and untouching? Associated vomiting, upset tummy, fever, intermittent continence. Did you take any medicines for that? Now, if the patient, like that of Girija's case, if she's in discomfort, settle the patient. You give the painkiller, medicines for vomiting and oxygen. Pause and seek permission to continue. Remember, there can be an ectopic pregnancy in pain. Now, avoid congratulating if she is with early pregnancy complications like ectopic, threatened miscarriage. Don't congratulate for this pregnancy in exam, right? Now, if your HOPI is regarding vomiting, so since when are you having vomiting? Are you keeping fluids and food down? Tried any medication so far? Have you lost weight? Any associated symptoms like fever, waterworks, bowel problems? Did you have this in the previous pregnancy? Any ultrasound being done? Why? Because we are worried about the molar and the twin pregnancy. Some general questions regarding how are your periods? What is the current duration of pregnancy? How is the pregnancy going so far? Have you started your folic acid? What is your blood group? Have you been booked to the midwife? What's your dating scan? Labs down, screening done? Do you know the results according to the gestation? Okay. Then obstetric history would be first. Why? Because this is a pregnancy case. Then gynae history, medical history, family, surgical, drugs, allergy, personal, social, and mental. If it is a revealing diagnosis of that of miscarriage or an ectopic pregnancy, we'll do the breaking bad news. And if it's a simple case, then of course you'll skip it up. Then you'll come to the management plan according to the cause. You will address patient's concern. closure admission if it's something like heavy bleeding or pain, and you can call her for the follow-up as well if it's simple threatened miscarriage. Done? The basic template of early pregnancy, how you're going to prepare for the next 1 week for a Saturday class. And the topics, the 7 topics which we are going to do, I will just post in your study group today so that you start preparing. And you can find these from that booklet as well of PDF. Done? Right? These are all the questions I've given you. So go in a smooth manner, divide different parts in your station so that you don't have any trouble in your continuity and flow. I want to see every station as a passing station. There should be no borderline, no failing station at all. Now the group performance. I've taken first 2 days off from the group performance, friends, because the first 2 days you were trying to settle down with the type of meeting. The best group this week had been group. Which group was the best group this week? There were changes in the first 2 days where people were settling, like 5th of July and 6th of July. There were a little changes. However, batch A started beautifully. The first date from 5th of July, they started their presentations. They're starting gathering up, Sarwat, Dr. Atiya, Dr. Sabiha, starting with Rahma as well. Everybody was starting on a throttle, but the last 2 days, I could see a little ease. It would have been more in practice. And now I would like you all to work in the same manner. See, I'm giving you an organized pattern. Tell me where you are stuck up. Tell me that we are not finding lines for this. Tell me that in preparation of what topic you are having some difficulty. But an organized preparation, right? Start from day 1, distribute the topics. One person is going to make a template for one so that templates for others, they get ready automatically. So this is the benefit of doing in a group, right? So everything which would be ready for all of you. Batch A started at a throttle, but the last 2 days, they were lacking in their participation. And I could see that, you know, people were not together in the last 2 days. Regarding group B, the previous first 2 days, I was after them to start the practice, but the last 3 days they were doing practice. But still, I would like Salma, I know you're not here. I would like you to take lead, please. And the participation should go well. The continuity and the flow should go well. Everybody should be participating, and please speak more. Communication really matters. And the more you're going to speak, benefit it would be for your participation. The group C when started, again, in the first 2 days, there was a little confusion making the Skype IDs and all, but the last 3 days were really good. And now they were like very fluent in this. And I'm happy with the group C and the group D activity. Group D, again, when there were first 2 days, there was a little trouble with the Zoom, but now in the last 3 days, they were really good. Practicing so many stations, like today was an exam. And yesterday, all of them were like preparing in a manner there was a lack of this feel in group A. They were preparing for today's session yesterday, telling each other that today as if it's a final day. If you're going to prepare in this manner, believe me, your participation should be perfect. And your exam would be easier. This idea of giving you this stress today is that yes, your exam preparation would be perfect. Do you people get my point? That today in time, if you're going to prepare all these things, just tell me the last 1.5 and 2 months, how smooth they would be. And this is my idea of giving you this preparation task, that yes, you are going to make your templates ready, right? This is, of course, this is batch D, Divya. No, batch D was the best batch today, and they were best in their participation. I'm sure the batch C is very close to batch D, but A and B, you need to work a little harder. Okay, if I talk about the presentations, Sarwat was passing, Girija, yes, you were passing, Harshiba was also, these were all the best presentations. So structured discussion by Dr. Sarwat was really good. I'm worried about the group. So Dr. Sarwat, please take the lead in group A, and everybody should be on toes. And I know you can do that. Even if Dr. Atiya is busy someday, keep everyone, Dr. Sarwat, on toes for the group A, okay? And Salma and Dalia, please, group B, and I want all of you to be active. All right? Getting that? So would I see a change in the coming week? Would I see a change in the coming week? If not, then I would not be solving questions for all of you. My effort would be 100%, but I want a 200% response from my students. I will have sleepless nights in solving these questions for all of you, but in return, I want a response. I want a better presentation from the previous one. If the graph would be rising, yes, I'm satisfied. But if the graph is not rising, then it's a failure for me as well. And of course, it's your exam in the end, you are getting affected as well. So we all are going to make a right directional practice so that we make it a success, my dear. We cannot pick up these books again and again. We have got kids, we have got families, we have got jobs. We have to move forward in our life. So this is the only exam chance which we are having. Okay, so Sidra ma'am needs hard work in the right direction, and that is must. And I would see now that for next 1 week, who presents the best, and I would see in the mini group who is going to have a better presentation. Very good, Dr. Sujata. I love you for that. Very good, Dipti. I would like to see change in each one of you. Very good, Nadra. Please take the lead in the group D, please. Somebody has to, encourage one another that yes, we have to pass this exam. We don't have to keep each other lagging behind. Done? Would I see the change? Yeah? Okay, so with this promise that I'll see the change in all of you and we all have to pass it together, we are calling it a day. So thank you very much. Any questions you people have? Thank you, Harshiba. Perfect going, my dear. You all have to prove yourself that yes, we are past candidates and you have to be best in the competition. That's my requirement from all of you. All right. Thank you very much. So any questions you people have, I'm here to answer. Again, if you people want to ask anything in the mini groups, just tag me or send a voice note. I'll be there to answer as well. Thank you very much, all of you. Take very good care of yourself. Have a good dinner and sleep tight, and give tomorrow to the recording. I will just post the recording maybe 2 to 3 hours. I'll update on your Gmails. Just go through the recording and complete your templates tomorrow. And then you've got 5-6 days to complete your early pregnancy tasks. I'll be posting the tasks just in a bit in your study group. All right.
So Dr. Sidra, please start this group monitoring from day after tomorrow. Tomorrow is for recovery of these previous stations. Yes.
No, completing of previous station, you have to give a thumbs up in the mini group that you have completed the previous station. Then I'll mark you on that.
Yeah.
Okay. No gathering up. Even if you don't want to do that, that's okay. But everybody has to write in the mini group that you have completed your sexual module, these 7 stations. Nothing should be lagging behind. You'll write it there.
Sure,
I'll mark you guys 10 by 10 when everybody would be there saying that, yes, our sexual module is finished, Sidra. So we are moving toward the early pregnancy. I'm going to be strict on that. Okay. So you do that. And from next day, today is Friday, right? Saturday, you're going to give to that. And from Sunday, you will, in fact, you distribute your topics on Saturday from Sunday onwards. So that Sunday person knows that who is doing which station. Okay. So from Sunday, you are starting your early pregnancy. Done? Okay. Done. So please, yeah, yes. Very good. Well done. So take very good care of yourself. I'm all there available for you guys. Just I need in response a good practice and a good participation. I need to improve each and every aspect in you so that we pass this exam. I will give my 100%. You'll always find me till your examination hall with you guys. But in return, I just need your hard work in the right direction. Okay. Thank you very much. Love from my side to all of you. Take very good care of yourself. Please. Yes, my dear, please.
Dr. Sidra, please try to give recording at night so that from tomorrow morning, the whole day, at least we complete this module.
I'll just take 2 hours for the conversion and cropping. That what is Zoom timing is, right? And immediately after that, I'll upload. Maybe after 2.5 hours. Thank you very much. Thank you. I'll just be awake. I'll convert it and I'll upload it on the Google. Okay. Right. Thank you very much. Okay. Take very good care of yourself. Love from my side. We'll meet again on Saturday. Till then, I'm available in the mini groups. Stay in touch with me. I love you all. Take care. Bye-bye from my side. Have a good night. Thank you.